0.8% was due to infection, which was not seen in high-income countries and middle-income countries. So the problem was, at least the problem was identified, that these data suggest that the majority of stillbirth in our region is due to unidentified causes. This is because in low and middle income countries, the causes are mostly identified by verbal autopsy and clinical determination. These gaps in understanding the causes of stillbirth have contributed to the slow progress in reducing stillbirth incidence. Now, how to bridge these gaps? First, we will have to list the causes of stillbirth so we can work on that and prevent this condition. So this is an algorithm for etiological investigation of stillbirth, stillborn infant. First one is maternal family history, then maternal investigation. Then we go for stillbirth examination, which is a very important part. In this, we go for physical examination, clinical photographs, radiological studies, autopsy, consult, then cord examination, placental examination, and then cytogenic investigation. All the informations collected with these are used in counseling. So any solution, one tool to improve specificity when identifying the cause of stillbirth is minimal invasive tissue sampling, that is MITS, a process of fetal tissue sampling by needle biopsy, which has been used as a less invasive autopsy for histological and microbiological evaluation on selected tissues. With additional consent from women, needle biopsies from the lung, liver and brain tissues are done by a trained technician. These samples are subsequently analyzed by histological and PCR testing. This is a substitute for autopsy, which is generally very difficult to ask a parent in India or any country. This is a difficult condition situation, so we can go for MITS. Next is physical examination. Each stillborn baby should have a physical examination after delivery, including assessment of birth weight, length, head circumference, and evaluation of signs and degree of maceration. After this placental examination, it can be examined grossly and histological, and if possible, PCR should be done on placenta, umbilical cord and membranes. So with these, how much we understand, the two major stillbirth research studies done on our specific population are PURPOSE and CHAMPS. And what these studies found, that the most common primary fetal cause of stillbirth was intrauterine hypoxia, followed by fetal infection and growth disorders. Hypertensive disease was the primary maternal cause, followed by anemia and maternal infection. Placental and umbilical cord conditions were an important primary or contributing factors, mostly involving placental malperfusion and hemorrhage. So we need evidence-based interventions, like, for example, syphilis treatment in pregnancy might prevent more than 7.7%, that is more than 2 lakhs of stillbirth. And malaria and syphilis are quite common in low income and middle income countries. After that, fetal heart rate monitoring and labor surveillance are crucial for preventing 1.3 million intrapartum stillbirth. Stillbirth prevention and response cannot be a standalone issue and requires an integrated programmatic approach. So what we do, we start with reproductive health planning and preconception care, like family planning, good health and nutrition, including folic acid, for prevent anemia, iron, protection of the girl, promotion of adolescent health, education and empowerment. When pregnancy comes, antenatal care package should be delivered in high quality. Prevention and management of maternal infection, management of maternal hypertension and diabetes, detection and management of fetal growth restrictions and respectful care. Then childbirth, supporting a safe childbirth, labor and childbirth care package delivered with high quality, fetal surveillance, and after that post-term labor induction, if appropriate in health system context, respectful care. And after that, if a death occurs, respectful and supportive care is very important. Postnatal care package with high quality, respectful supportive care for the mother, her family and the community. Perinatal audit and response. So this is a integrated approach which can help us to prevent stillbirth. We can't come in the last trimester and we are going to prevent stillbirth. No, we have to start it with adolescent. To improve care for future or for further, we need priority actions to change the trends for stillbirth. Like in intentional leadership, we have to focus on stillbirth prevention, increased voice, implementation of integrated interventions, indications to measure impact and monitor progress, investigation of crucial knowledge gaps. So this can be, we can start with awareness, knowledge, saliency, attitude, self-efficacy, intention, and behavior. So this is a simple 3 ways we can ask a patient, which can help and definitely help us in reducing the incidence of stillbirth. Sleep on your side, monitors baby's movement, and quit smoking. Smoking is not, if not active, passive smoking is very prevalent in India. So this is, you were born silent, perfect and beautiful, still loved, still missed, still remembered. Every day, stillborn, but stillborn. Thank you.
Thank you, ma'am.
Thank you, Dr. Divya. It was a very nice presentation. You included all the major components that need to be taken care of. And the most important ones are tracking the high-risk pregnancies, managing the labor effectively, monitoring the baby during labor. But still we have many unexplained. And those unexplained stillborns are basically because of the Doppler changes. Yes. So, third trimester ultrasound with Dopplers is a must, as Dr. Ashita may agree with this. A third trimester ultrasound with Dopplers at 36. But, yeah.
Can we have the next speaker, because there are 10 minutes for discussion right
Thank
at
you,
the
Dr.
end.
Divya.
Yes, we have Dr.
Thank you so much.
Nutan
Thank
Narayan
you.
next.
Our next speaker is Dr. Nutan Narayan. She is assistant professor at NMCH. Ma'am is very knowledgeable and she is very famous among her PGs.
Thank you, Chairperson. Thank you, Shraddha.
Very favorite also.
That's very generous of you. So, my topic is oligohydramnias and approach to better feto-maternal outcome. So what is amniotic fluid? This presents from early pregnancy and is produced almost exclusively by the fetus. And oligohydramnias refers to amniotic fluid volume that is less than the minimum expected for that gestational age. The volume of amniotic fluid changes over gestation and increases linearly until 34 to 36 weeks and then remains constant and decreases post-term. The incidence, if you use AFI less than 5, is 10%. This is the graph how the amniotic fluid increases and then decreases. So how do we assess amniotic fluid? It is mainly an ultrasound diagnosis. So either we do maximal single vertical pocket or amniotic fluid index, in which oligohydramnia is less than 2 if it is maximal single and amniotic fluid less than 5 centimeter. This is how we do on all 3 pockets, and it should be cord free. So what is the source of amniotic fluid? It is, as I've said, it is mainly fetal, the fetal skin or from the placenta, amniotic epithelium, transudation from the placenta, and it also gets absorbed like intramembranous absorption and exchange from lung fluids and swallowing from fetus, and the fetal urine is also produced. In the first trimester, the etiology is a bit different. It is called coelomic fluid and is present between the developing chorionic and amniotic membranes. And this composition is more similar to maternal plasma than of the amniotic fluid of the later pregnancy. And at the end of first trimester, it disappears completely. And alongside the second trimester and the third trimester, the amniotic fluid, as we know, starts getting produced by direct production from placental surface, secretions from the embryo screen, transport across amnion, fetal kidneys, fetal lung. The fetal kidney and the urine, they actually start from the 18th week to 20th week. So in the first trimester, we do not get, if there is any abnormality, we will not be able to see. Why is amniotic fluid important? Because it forms a protective layer, as you all know, around the fluid, and it protects the baby from shock, trauma, and also it has an important role in growth, development, and therefore good pregnancy outcome. Also in now times we can say the amniotic fluid provides useful information about being well-being and maturity of the fetus, and a lot of amniocentesis is being done for a lot of conditions, maybe genetic also. So what are the fetal complications which can lead to oligohydramnias? We all know fetal urinary tract abnormality, but this we can see only after 20 weeks. And uterodevelopment insufficiency, fetal growth restriction, that is one of them. And maternal conditions in which this chronic hypertension, preeclampsia, SLE, diabetes, APLA, these are one of the most common ones. But there are multitude of, like this attitude is, etiology is multitude. I will not go into any of them detail. The complications, they of course depend upon the, what is the period of gestation. There can be abortion or deformity, cord compression in the 3rd trimester, meconium stent, and then fetal acidosis and low upgar, and the mortality is quite high. For the maternal side, they usually does not have any effect on the health, but the morbidity and the operative interference is much increased. This is a typical Potter syndrome or the Potter facies, which because of the compression, low like a volume, the compression by the uterus, and this facies comes. So diagnosis, we all know, uterine size should be smaller, less fetal movements, uterus feels full of fetus, easy palpation, malpresentation is very common, and it is associated with FGR, and sonographic diagnosis we have to do, and we have to see AFI or the single vertical pocket, and then we also have to see for the fetal abnormalities. And the later stages, we should go for the Doppler studies so that we know when to take out the fetus. So these are the 1 or 2 case presentations, like in the 1st trimester oligohydramnias, 25-year female came, 7 weeks. The mean sac diameter was 14 and the crown lump length was 12. So when the difference between the mean sac diameter and crown lump length is less than 5, we can call it 1st trimester oligohydramnias. And the prognosis for this is not good. And this, after 13 days, it was failed early pregnancy. In the 2nd trimester, another patient, 35-year-old gravida 2, she presented, and for her, the 1st trimester genetic screening was normal. Scan at 24 weeks showed fetal ascites scalpedema, and amnioinfusion was done, and serial ultrasound was done. At 28 weeks, then the urinary tract abnormality came into the ultrasound report, that was distended bladder and keyhole appearance. And it was diagnosed as lower urinary tract infection, obstruction. Then, but still the pregnancy was continued, and at 34 weeks there was a sudden drop in AFI, and it was seen that the right fetal kidney and fetal urinary output was, the kidney was being affected, and so there was an emergency cesarean section, and the baby was taken out. So we see that although in the 2nd trimester, if it is isolated oligohydramnias, it doesn't actually have an adverse outcome, but if the fetus is involved, then the outcome is not good, because even with this case, there was difficulty in reviving the fetus. So how do we manage? In the 1st ultrasound, we do not have to do anything, only serial ultrasound and wait and watch. And the 2nd trimester, we have to evaluate whether it is an isolated or it is due to some fetal growth, but we can manage this patient in outpatient, and we can increase amniotic fluid volume by various methods that we have, amnioinfusion and given oral or IV fluids. In 3rd trimester, if it is oligohydramnias, we admit the patient to the hospital, and antepartum surveillance, as we have already seen, that should be done by ultrasound, NST, BPP, and maternal hydration. It means because this can increase the liquor volume by 4.5 if it is a placental cause. So we can give oral, and then we can give amnioinfusion. If it is associated with premature rupture of membranes, then seeing watching for chorioamnionitis, we can prolong the pregnancy as much as possible and then take it out. And of course, because there's high chance of fetal congenital anomaly, we must also have a fetal medicine unit. And if it is post-term, then they have to be delivered either by induction or by cesarean section, it does not matter. This is how amnio infusion is done. It is transabdominally and ultrasound guided. This, I will not go into the details of this, but this can be done repeatedly to help the volume of amniotic fluid. And of course, the placenta has to be localized and painting draping, and 20 kg needle is used, and normal saline is injected. And if it is Rh negative, then anti-D should be given. So when we see the prognosis, for the first trimester we have seen it is not good. For the second trimester, if it is borderline or low normal amniotic fluid, we can say good prognosis as in third trimester, but we have to be vigilant. And if it is very much oligo, that is less than 5, so the pregnancy outcome is usually poor, because it is usually due to the fetal malformation. In the third trimester, we can have umbilical cord compression, uteroplacental insufficiency, and these all can be managed by ultrasound, serial ultrasound.
Sorry to interrupt, but the time
over.
has run out, yes.
So if we are managing it, the outcome is usually good, but as I've said, morbidity and operative interference is increased. Thank you very much for your patient hearing.
Thank you, ma'am, for your excellent talk. It was very clear to all of us.
We now hire Dr. Ranjana Sinha for her talk on puerperal pyrexia. She is ex-head obs and gynae, East Central Railway, Patna. She has many important positions in ISOPARB
Thank you,
and
Monica. Let us start.
POGS, and she is a very dear senior.
So
over to you, ma'am.
Respected Madam Pramila Modi and all my seniors, and my honorable chairpersons, Dr. Monica and Dr. Shraddha. I'm very much thankful to Dr. Abha Rani Sinha and Dr. Nibha Mohan and the scientific team for giving me this opportunity. So just look at the deep delving eyes of this beautiful actress, Smita Patil, who died due to puerperal complications just 2 weeks after birth of her son on 13th December 1986 at the age of 31. And that is so horrific. We all felt so bad. So my topic is puerperal pyrexia. By definition, puerperal pyrexia is defined as a temperature greater than 38 degrees centigrade on any 2 of the first 10 days following delivery, exclusive of first 24 hours. From day 2 to day 10, if the pyrexia occurs, it is called puerperal pyrexia. Incidence, it is relatively common. Approximately 5 to 7% of births may follow with pyrexia. Majority cases occur more than 2 days after birth, and infection is the most common cause of febrile morbidity. And just remember that maternal sepsis accounts for 11% of deaths among the causes of maternal mortality. So be vigilant. The causes include infections which may be bacterial, viral, parasites and protozoal. There may be inflammations, it may be iatrogenic, excessive trauma to the tissues and rare malignancies. Regarding the pathophysiology, the infections, most common infections occur in endometrium, so endometritis, mastitis, post-surgical wound infections, perineal cellulitis, UTIs, septic pelvic phlebitis, and respiratory complications from anesthesia may cause pyrexia. Regarding transmission, there may be endogenous organisms from the mixed flora colonizing the woman's own genital tract, that is most common. Exogenous from external contamination like deliveries under unhygienic conditions, and nosocomial acquired from hospital environment. Important pathogens, Streptococcus pyogenes, Escherichia coli, Staphylococcus, Streptococcus pneumoniae, MRSA, Clostridium, and Morganella are the most common organisms found.
The general risk factors which predispose are maternal, like pre-existing STIs, RTIs, diabetes, poor patient hygiene, obesity, etc., and related to delivery. Most important is failure to follow infection prevention practices, home birth in unhygienic conditions, frequent vaginal examinations, PROM more than 18 hours, prolonged or obstructed labor more than 24 hours, C-section, instrumental delivery, PPH, and many other causes. But when we come to prognosis, if we have high index of suspicion and if early intervention is done, the prognosis is good with prompt and appropriate therapy. And in maternal death in puerperal sepsis is around 0.6 maternal deaths per 1 lakh live births. And if not properly treated, not taken care of, the complications may be severe, like septicemia, endotoxic shock, peritonitis, abscess formation, compromised future fertility, and in rare cases, death. So early diagnosis of is the key, and which begins with a proper history taking. Just ascertain if the delivery was vaginal or cesarean, where there was a history of PROM, whether the patient received any antenatal care or not, whether she was treated or diagnosed with any infection during pregnancy. Coming to the symptoms, physical examination should focus at identifying the source of fever and infection. Endometritis presents with lower abdominal tenderness on one or both sides of abdomen, foul-smelling lochia, adnexal and parametrial tenderness elicited with bimanual examination and temperature elevation. Wound infections may present with erythema, edema, and tenderness out of proportion to expected postpartum pain and discharge from wound. Mastitis, very tender and gauze, erythematous breast, frequently unilateral, UTIs, and just think of pyelonephritis also here, respiratory tract infections, and most importantly, septic pelvic thrombophlebitis with palpable pelvic veins, tachycardia that is out of proportion. Just also think of other conditions like appendicitis, cellulitis, deep vein thrombosis, PID, pyelonephritis, TO mass, and vaginitis. So investigations are very important, that should be prompt. Blood cultures are the key investigation and should be obtained prior to antibiotic administration. However, antibiotic administration should be started without waiting for microbiology results. Serum lactate should be measured and within 6 hours of suspicion of severe sepsis to guide management. So in case of severe sepsis, if the lactate is more than 4 millimole per liter, it is indicative of tissue hypoperfusion. Imaging studies such as chest X-ray and ultrasonography are required in some cases, and CT may be required if pelvic abscess is suspected. Routine blood tests like blood count, urea electrolytes, and CRP may be done. And blood culture, throat swabs, midstream urine, high vaginal swab, placental swab, CSF, epidural site swab, cesarean section or episiotomy site wound swab, and expressed breast milk can be examined as and when required. Regarding treatment, besides supportive measures like hydration and antipyretics for fever, the basis of treatment is antibiotics. For endometritis, the choice of treatment is aminoglycoside and clindamycin, or aminoglycoside plus metronidazole with or without ampicillin. In mild cases, it should be given orally. In moderate cases, parenteral antibiotics should be given. For UTIs, appropriate antibiotics like trimethoprim, sulfamethoxazole, nitrofurantoins, and fluoroquinolones can be used, and they should preferably be given after breastfeeding. Fever and flank pain, just remember pyelonephritis and admit the patient. Regarding septic pelvic phlebitis, ampicillin, gentamicin, and metronidazole or clindamycin is preferred antibiotic with anticoagulation. Initial bolus of 60 units per kg followed by 12 units per kg per hour of heparin is recommended, or low molecular heparin 1 milligram per kg with APTT monitoring. And when to hospitalize the patient. Women with sepsis in the puerperium are best managed in a hospital where diagnostic services are easy to access and intensive care facilities are readily available. Patients with postpartum endometritis, post-surgical wound infection, or if the patient is clinically unwell, with vomiting, admission should be considered. Monitoring should be done through a multidisciplinary approach with a senior obstetrician in consultation with an intensivist and microbiologist, and regular observations of all vital signs should be recorded on a modified early obstetric warning score MUE chart. So this is the Muir's chart, which with respiratory rate, oxygen saturation, temperature, systolic blood pressure, diastolic blood pressure, heart rate, and neurological response. If it is in yellow alert zone, consult senior obstetrician, give blood culture, and monitor the patient. And if there are red flag signs like pyrexia more than 38 degrees centigrade, sustained tachycardia more than 90 beats per minute, breathlessness, abdominal or chest pain, diarrhea, vomiting, uterine or renal angle pain, and tenderness, or woman is generally unwell or seems unduly anxious, it should prompt early urgent referral and hospital assessment, and if the woman appears seriously unwell, by emergency ambulance. Tasks to be performed, just 2 minutes. Yeah. Tasks to be performed, just a minute. Within first 6 hours of identification of severe sepsis, obtain blood cultures prior to antibiotic administration. Administer broad spectrum antibiotic within 1 hour of recognition of severe sepsis. Measure serum lactate. In the event of hypotension and or a serum lactate greater than 4 millimole per liter, deliver an initial minimum 20 ml per kg of crystalloid or an equivalent. Apply vasopressors for hypotension. In the event of persistent hypotension or serum lactate greater than 4 millimole per liter, achieve a central venous pressure of more than 8 and central venous oxygen saturation of more than 70. In emergency department, you will also have to do the other care like wound infection or episiotomy infection treatment like drainage, debridement, etc. Mastitis treatment. The most effective treatment is managing mastitis is effective milk removal or fluid mobilization. Supportive measures include rest, adequate fluids and nutrition. Also use local measures, and if breast abscess is present, then a breast pump should be used for a lactating woman, and mothers, if there is no breast abscess, the mother may continue to breastfeed baby. Indications for admission to ICU: if there is presence of shock or other organ dysfunction, the mother should be admitted to ICU. In severe sepsis only, there is role of IVIG. So most important part is prevention. Prevention of puerperal sepsis, because that is the most important cause of puerperal pyrexia. So during delivery, emotional support by allowing companion, use of partograph to avoid prolonged labor, limit vaginal examinations, and follow asepsis during delivery, the 6 cleans. Delivery should be by trained personnel, and most importantly, after delivery, maintain perineal hygiene and use clean sanitary pads. So the take-home message: postpartum pyrexia requires prompt intervention. Postpartum pyrexia can progress rapidly and result in severe maternal morbidity and mortality. A full history and examination through thorough investigation, close observation and prompt treatment can save lives. A high index of suspicion is needed for conditions such as septic pelvic thrombophlebitis or ovarian vein thrombosis that cause enigmatic fever, where the history is vague and usually no localizing signs are found on examination. Involvement of multidisciplinary team, aseptic precautions, and use of antibiotics are the key points. And the sepsis 6 is an aid to streamline management within 1 hour of initial recognition of sepsis. So know your sepsis 6 well, give high flow oxygen, take blood culture, give in IV antibiotics, give a fluid challenge, measure lactate, measure urine output. By doing these 6 simple things in the first hour, you can double your patient's chance of survival. Thank you very much for your patient listening.
Thank you so much, ma'am, for emphasizing the early diagnosis, and when we act early, we get better outcomes. Thank you so much.
Our next speaker is Dr. Mini Anand, and she's got a deal with me. She's going to put a 10 minutes timer, और 1 सेकंड उसके आगे नहीं जाएंगे. मुकुंद, timer 10 minutes, stop कर दे. Yes.
Yeah. So our next speaker is Dr. Mini Anand. She is Senior Consultant and Director of Sun Hospital, Patna. Ma'am is Professor at Madhubani Medical College, Consultant at Nova Fertility Clinic. Ma'am has held various positions in ISOPAB, in POX, and
Thank you, dear Shraddha. Thank you so much.
And your field of interest is high-risk pregnancy and cosmetic gynecology.
Dear chairpersons, respected seniors, and my dear friends, I will be talking about hyperemesis gravidarum, or HG in short, which I will be saying out quite a few times. Now, hyperemesis gravidarum is a severe type of vomiting of pregnancy which has got deleterious effect on health of the patient or incapacitates her day-to-day activities. Now, it affects about 0.3 to 2.3% of all pregnancies. According to RCOG, hyperemesis gravidarum can be diagnosed when there is protracted nausea and vomiting of pregnancy, along with the triad of more than 5% pre-pregnancy weight loss, dehydration, and electrolyte imbalance. Now, few women are more prone to having HG, and these are women with multiple fetuses, those with a molar pregnancy, young primigravidae, very obese or underweight women, women with maternal history of nausea, vomiting of pregnancy, those with personal history of motion sickness or migraine, and even those with unplanned pregnancies. The etiology is unknown, but certain factors have been implicated. I'm not going to go into the detail. The most important is the hormonal stimulus, and especially human chorionic gonadotrophin, because there's a clear-cut connection between the two. As the HCG peaks, we can see peak symptoms of nausea and vomiting of pregnancy. It should be treated promptly because it has quite a number of complications, serious complications, and there are few of them are vernix encephalopathy as a result of prolonged B1 deficiency, central pontine myelinolysis. Now this occurs as a result of prolonged hyponatremia, splenic avulsion. As a result of excessive retching, there could be esophageal tear or rupture, pneumothorax, ophthalmic retinal hemorrhage. There could be peripheral neuritis as a result of chronic B12 deficiency, and systemic review demonstrated significantly higher depression and anxiety scale scores in women with HG, so much so that it prompted these women to go to their clinicians and they asked for a medical termination of pregnancy. And then there could be convulsions or even coma. The only prevention is to correct simple vomiting of pregnancy. Now, coming to the diagnosis, pregnancy has to be confirmed first. Other associated causes of vomiting should be excluded by a clinical history, a very focused examination and investigations, and the differentials include peptic ulcers, cholecystitis, gastroenteritis, hepatitis, pancreatitis, genitourinary conditions such as UTIs or pyelonephritis, many metabolic conditions, neurological conditions, and also drug-induced nausea and vomiting. And that's why a thorough history has to be taken. So in history, we must ask for previous history of NBP or HG, a personal history of motion sickness and migraine, history to exclude other causes like abdominal pain, urinary symptoms, infection, drug history, and chronic Helicobacter pylori infection, because that is also very important in India. A thorough examination must be carried out, and everything included: temperature, pulse, BP, oxygen saturation, respiratory rate, a thorough abdominal examination, look into the weight of the patient, look for signs of dehydration, muscle wasting, and other examination as guided per the history. Investigations, thorough investigations must be carried out, firstly to confirm that it is hyperemesis gravidarum and to rule out the other differentials. Therefore, urine dipsticks, which will quantify ketonuria as 1+ ketones or more, midstream urine sample, urea and electrolytes, because we know there could be hypokalemia, hyponatremia, dehydrations, and then there also could be renal disease. A full blood count to look for infection, anemia and hematocrit, blood glucose monitoring to exclude diabetic ketoacidosis if the patient is diabetic, ultrasound scan to confirm viable intrauterine pregnancy and to exclude multiple pregnancy and trophoblastic disease. And in refractory cases or with history of previous admissions, one must look into thyroid function tests, because both hypo and hypothyroidism can mimic signs of nausea and vomiting of pregnancy. LFTs, we all know, to exclude other liver diseases, amylase to exclude pancreatitis, and arterial blood gases to exclude metabolic disturbance to monitor severity. The principles of management basically are to control vomiting, to correct fluid and electrolyte imbalance, and to correct metabolic disturbances, and all this to prevent serious complications of severe vomiting, because we are really worried about the complications. Now, women who have vomiting but are not dehydrated can easily be managed with antiemetics, oral hydration, and dietary advice. They can remain at home and very much ambulatory. Now, ambulatory daycare management is associated with high patient satisfaction, but if they do not, they are not adequately, if they do not respond to this daycare management, they can be managed as an inpatient due to associated complications. So now these are the ACOG guidelines as to how to manage NVP and HG. Now as I said, prevention is the only cure, so we must try and prevent nausea, vomiting of pregnancy. As soon as the patient comes with this, put her on ginger capsules, 250 milligram 4 times a day. If she does not respond, add vitamin B6 along with doxylamine, which is an antihistaminic, and a maximum dose of 40 milligrams in divided doses, and it should preferably be given empty stomach. In case if she does not still respond, then we can add other antihistaminics and prothiogens like dibenzhydronate 25 to 50 milligram and diphenhydramine 25 to 50 milligram every 4 to 6 hourly orally. Or we can add prochlorperazine and promethazine 15 to 25 milligrams again orally. Now, if still she does not respond and there is no dehydration, add metoclopramide 5 to 10 milligram every 6 to 8 hourly, orally or intramuscular. Or even ondansetron can be given 4 milligram orally every 8 hours. But if there is dehydration, we have to add intravenous fluid replacement has to be given, and in these cases metoclopramide 5 to 10 milligram intravenously every 8 hourly, or ondansetron 8 milligram over 15 minutes every 12 hourly intravenous. And if still she has persistent symptoms, which means it is a refractory case, then corticosteroids must be added. IV hydrocortisone can be given 100 milligrams BID, and as soon as there is clinical improvement, switch over to the oral therapy, which is prednisolone 40 to 50 milligrams OD. Taper over 2 weeks to the lowest effective dose, and if beneficial, limit total duration of use to 6 weeks. Now, there are safety and efficacy data for first-line antiemetics, such as antihistamines and phenothiazines, as I said, and they should be prescribed when required for NVP and HG. Combinations of different drugs should be used in women who do not respond to a single antiemetic according to the RCOG Green Top guidelines. Now, metoclopramide is safe and effective, but because of the extrapyramidal side effects, it should be used as a second-line therapy. A review of metoclopramide, which was conducted by the European Medicines Agency's Committee for Medicinal Products for Human Use, has confirmed the risk of short-term extrapyramidal disorders, particularly in young women, and therefore the review recommends metoclopramide should be prescribed for short-term use only, a maximum of 30 milligram in 24 hours and maximum duration of 5 days. And if it has to be given IV, it should be given a slow bolus injection over at least 3 minutes to help minimize these risks. Studies on safety of ondansetron are mixed. The use of ondansetron should be limited to patients who are not adequately managed with the above mentioned antiemetics, and preferably used after the first trimester of pregnancy. Regarding IV fluids, there is no evidence to determine which IV fluid regimen is most appropriate. But given that most of these women admitted to hospital with HG are hyponatremic, hypochloremic, hypokalemic, and even ketotic, it seems appropriate that we use normal saline along with potassium chloride. In case we are using dextrose, because there could be, because of prolonged vomiting, there could be deficiency of vitamin B1, so it could precipitate vernix encephalopathy. Therefore, in thiamine deficient states, if we are giving dextrose, then thiamine 100 milligrams IV must be given. Now, corticosteroids should not be used until conventional treatment with IV fluid replacement and regular antiemetics has failed. The details of the dosages I have already mentioned. Therefore, to summarize, hyperemesis affects between 0.3 to 2.3% of all pregnancies. The condition is defined as uncontrolled vomiting requiring hospitalization, severe dehydration, electrolyte imbalance, and weight loss of more than 5% of body weight. And most of these patients who do not respond, there could be hypokalemia, hypochloremia, as I already said, and low serum urea levels. So these have to be promptly corrected to prevent all complications. Aggressive antiemetics, IV fluids, electrolytes should be given, and in refractory cases, corticosteroids. Thank you very much for a patient hearing.
Now, can I request all the speakers to join us on the stage for a few minutes of discussion or a photograph, whichever is possible. Chairpersons, over to you.
Thank you, Mini Ma'am, for the excellent talk. Yes, hyperemesis gravidarum is such an important topic. If not corrected at the right time, it really affects the quality of life of the mom at that time.
Can I request all to please come forward? Can I request Dr. Abharani Sinha, Dr. Alka Pandey ma'am to also join in for the picture? Dr. Supriya Jaiswal. All right. In the meanwhile, जैसे photo लिया जा रहा है, can I? We have a question as well. Can we just know this question is addressed to?
Mini Anand.
Dr. Mini, this is for you.
Yes, corticosteroid helps. Yeah.
डॉक्टर रंजना को डॉक्टर लक्ष्मी झा भी फ़ोन कर रही है 3 बार, रहा नहीं जा रहा है उनसे, मैं कट करते जा रहा हूँ, वो फ़ोन करते जा रही है. डॉक्टर मिनी, इफ यू कुड आंसर दैट क्वेश्चन.
Leads to immunomodulation, madam. That is the important. That is because of that it prevents hyperemesis gravidarum. There are many factors involved. There are many theories. There are many etiologies. Because I did not discuss, I didn't have the time, so I could not discuss all. There are many factors involved, though we do not know exactly how they work. The most important was one factor only, which I discussed regarding HCG. Because when there's rise in HCG, it causes maximum. We see peak symptoms of NBP. I did not discuss the other factors. So this was the reason why corticosteroids should be given. So, yes, ma'am. That's why this is. Right, and that is why they have to be used. I was specific in saying that they should be used only for 6 weeks. They have to be limited. As soon as there's clinical improvement, switch over to the oral form and then try and decrease as fast as possible, looking into the clinical improvement of the patient.
Yes. Thank you so much. With that, we would like to get started with our next session. Can I request the chairperson, Dr. Charu Modi ma'am, to please join us on the stage. As you can see,
good morning, everyone. As the next chairperson is yet to join, I would like to request the chairperson scientific, Dr. Abharani Sinha madam, to kindly join.
ये मूव नहीं कर रहा है. Okay, yes.
With the permission of Dr. Abharani Sinha, I would like to call upon Dr. Supriya Jaiswal to kindly present her talk. She'll be speaking on instrumental vaginal deliveries.
Trauma during vaginal birth.
Okay, sorry. Trauma during vaginal deliveries. Please go ahead.
Thank you very much. A very good morning to all of you, and it's pleasant to see everyone present here at such an early morning, 9 o'clock. Thank you, dear all. And respected chairpersons, shall I start the talk? So, trauma during vaginal delivery. So, patient safety during childbirth can be assessed by looking at potentially avoidable tearing of the perineum during vaginal delivery. Such tears extend to the perineal muscles and bowel wall, require surgery. More likely to occur in the case of first vaginal delivery, high baby birth weight, labor induction, occipital posterior baby position, prolonged second stage of labor and instrumental delivery. Possible complications include continued perineal pain and incontinence. Not possible to prevent in all cases, but can be reduced by employing appropriate labor management and high quality obstetric care. Preparation of delivery involving higher degree lacerations is a useful indicator of the quality of obstetric care. This is a little bit of epidemiology. The types of perineal tears, cervical lacerations, hematoma, fistulae and uterine rupture are most common. So you can see these are the types of the perineal tear that we usually encounter. So first degree tears, second degree, third degree, and fourth degree tears. So maternal risk factors are nulliparity, Asian ethnicity, these are the few factors. Fetal risk factors, large fetal weight, mostly this is the main cause for, and then the shoulder dystocia, occipito-posterior position. Intrapartum risk factors are many, like instrumental delivery. Once you use the forceps gives a very bad experience. Sometimes if not applied properly, really it gives a bad perineal tear. Then these are the few classifications, like first degree lacerations of the vaginal epithelium or perineal skin only, second degree involvement of the perineal muscle but not the anal sphincter. Third degree is in 3A, B and C. The fourth degree comes disruption of anal epithelium. So obstetric anal epithelium injuries, sphincter injuries encompasses both third and fourth degree perineal tears. So OSS complications are immediate postpartum period. Complications include bleeding from the laceration site, increased pain, wound infection and wound breakdown. Bowel control issues such as fecal urgency, anal incontinence, these and rectovaginal fistula formation are all significantly increased. Impact on future reproductive decision making, less likely to choose to have a subsequent baby. So this is a chart that shows it in detail. So OSS complications, psychological trauma, it really leads the women, leading to anxiety, depression and post-traumatic stress disorders occurs in up to 16% of women who experience a traumatic vaginal delivery. Development of anal incontinence, which occurs 5 to 10 years after the initial obstetric injury, can lead to further psychological damage and isolation related to embarrassment and decreased quality of life. So antenatal considerations to reduce severe perineal tears are perineal massage, use of devices, pelvic floor muscle training. So maternal position at birth is very important. Pushing practices during the second stage of labor is very important. You have to guide your paramedical staffs also. Then hands-on versus hands-off during crowning of the baby's head, instrumental vaginal birth and episiotomy. Management of perineal tears in the first degree, these tears are considered minor and are therefore left to the clinician's discretion to determine if suturing is required or not. Second degree, although these tears are also considered minor, sutures should be placed to facilitate better wound approximation. So principles of obstetrics, anal sphincter laceration repair, third and fourth degree. This is a flow chart you can see here. These are types of sutures and when we should do it properly so that the post-operative complications are less, the leaking is less, the wound healing is better. So these proper steps should be done by all of us, all the obstetricians. This is a cervical lacerations that is really gives you a nightmare. So we usually use the sponge holding forceps and the main point is we should catch hold of the apex properly. Intrapartum cervical lacerations are traditionally thought of as occurring due to the delivery of the fetus through the cervix at the time of vaginal birth. Cervical lacerations may also be noted at the time of cesarean delivery, particularly when the cesarean is performed during the second stage of labor from an extension of the hysterectomy incision itself. Data on the incidence, clinical characteristics and risk factors of intrapartum cervical laceration is very sparse. Still, we know that there are several deep cervical lacerations like precipitate labor. We don't often see these days precipitate labor, but that is an important cause of deep the cervical tear. Application of forceps with the cervix incompletely dilated. This is a major fault we have to take care. The cervix should be completely dilated once we apply the forceps. Rapid delivery of the head in breech presentation. A scar in the cervix may also cause tear. So management, prompt recognition of the injury and action to control the bleeding is essential. Good light for proper visualization of the tear is essential so that the patient should be taken to the theatre and examined under general anesthesia. By using 2 pairs of sponge forceps applied to the cervix at one end, any one time, it is possible to inspect the whole circumference accurately. In the identification of the apex of the tear is essential before commencing repair. Interrupted Dixon sutures can be inserted through the whole thickness of its wall. So this is the picture. These are the hematomas. Now coming to this is another complication. Vulval and paravaginal hematomas are seen. They are divided into infralevator, supralevator. Then hematomas of the vulva. This may be caused by rupture of the vulval varix. More often it occurs after perineal repair when a vessel is in spasm at the time of repair, relax and bleeds later. This is very dangerous. Once you shift the patient and then if she starts bleeding, it's really difficult situation. It can occasionally occur after normal labor with apparently intact perineum. So the hematoma appears suddenly as a very tender purple swelling on one side of the vulva. It may reach up to 10 centimeter or more in diameter. There is severe perineal pain and sometimes they go into shock. So any woman complains of severe perineal pain after delivery, the perineum should always be inspected before giving her analgesics. If the swelling is increasing in size and more than 5 centimeter, it should be incised and the clot turned out. If the bleeding vessels can be identified, it should be ligated, a drain is left in the cavity and a firm dressing is applied. If the hematoma is less than 5 centimeter and not expanding, it can be managed by observation using ice packs and pressure dressings to limit expansion. Then we have that broad ligament hematomas. This is uncommon accident after delivery. A deep vessel is torn at the time of delivery, goes into spasm and then relaxes after bleeding later. A hematoma forms above the pelvic diaphragm and spreads into the base of the broad ligament. It may also be seen with uterine rupture. So these are the clinical features like pain and deterioration of the women's general condition. There will be progressive anemia and slight fever. When the hematoma is large enough, it can be palpated on abdominal examination and it will displace the uterus towards one side. So the treatment is usually undergoes gradual absorption, but it will take several weeks if it is large. Infection is rare but may occur and lead to abscess formation. Most cases are treated conservatively with blood transfusion. Now coming to fistula, these are the types of fistula usually happens. Now the vesico-vaginal fistula, this may occur as a result of pressure by the presenting part in prolonged labor or by direct injury during operative procedures such as forceps or cesarean section. In obstructed labor, prolonged pressure between the head and the pubic bone may cause local ischemia and subsequent necrosis of the anterior vaginal wall and the base of the bladder leading to the vesico-vaginal fistula. Rectovaginal fistula result from third degree perineal tear with improper healing. The patient will complain of urinary or fecal incontinence. These fistula are uncommon now with proper obstetric care, treatment by surgical repair only. Uterine rupture you can see. So uterine rupture may be defined as disruption of the uterine muscle extending and involving the uterine serosa or disruption of the uterine muscle with extension of the bladder or broad ligament. Uterine rupture is associated with severe maternal and perinatal morbidity and mortality, and it remains one of the most catastrophic obstetric emergencies. Initial symptoms and signs of uterine rupture are typically non-specific, which makes the diagnosis difficult and may delay definitive treatment. There are many risk factors like previous cesarean section, previous uterine rupture, previous uterine surgery, excessive uterine stimulation with oxytocin, etc., trauma, uterine malformation, malpresentation, obstructed labor. Then the uterine rupture is managed in these ways. Everybody knows airway, breathing, circulation. You have to be very fast and whatever needed, like 2 large bore needle, IV cannula, blood count, everything should be done in a very fast so that we can save the patient. So this is thank you very much for the patient listening.
Thank you, Dr. Supriya, for finishing it before time, so
Yes.
that we have some time for discussion also.
Yeah.
So you have very well described all the injuries which occur during delivery. Regarding one point, repair of complete perineal tear, I would like to say that post-operative care is very important. That how you have to give laxatives right from the beginning so that the
Yeah.
patient does not have hard stool and the stitches they don't disrupt. I think that point is important.
Very.
The second point I would like to say that for the juniors, episiotomy, as you said, that sometimes you shift the patient to the ward and suddenly the patient goes into shock and then you find an hematoma. It's very important. Sometimes the patient they present with retention of urine. So anytime when you go to your postnatal ward Always ask the patient after normal delivery whether she has passed urine or not. I think these were the basics that we were taught by our teachers. So I think that point is very important. Again, one should always explore the cervix. I think that is a very important cause of traumatic PPH. So once there is a vaginal delivery, especially an instrumental delivery.
Yes.
After instrumental delivery, I think cervical tears are very common. So you should always have a PPH tray with 4 sponge holding forceps and 2 speculums, so that post-delivery, if the patient is having PPH, you should always make the habit of inspecting the cervix. Not just palpating it, you should always inspect the cervix.
Yes.
And broad ligament hematoma, I think any patient, and every time it's not palpable, so any patient who goes into unexplained shock after delivery, always think of broad ligament hematoma, especially if it has been a difficult delivery. Always think, because many a times we have found that the patient has gone into unexplained shock. These days we have ultrasound, we take the patient to the ultrasound and we can find the collection, but sometimes it may be missed if there are no facilities for ultrasound in the labor room. So I think these are the few important practical points that I wanted to share. Well done. Thank you.
Thank you, Dee.
Sure, Dr. Jayam Kannan, madam.
A good exposure also is very important when we should take them to the OT.
Yes, good.
I think all these things we had before 2010. The present era with misoprostol, 25 milligram being allowed in our country, even a normal delivery can go in for a cervical tear, and we have to inspect all patients who have been put on vaginal misoprostol and see that the cervix and vagina is normal before we ship them to ward. I had the last case seen with one of my colleagues 1 year ago in a third gravida. So I was really feeling very unfortunate that we are the cause of these problems sometimes.
Yes.
100% true,
Yes.
madam, and this is your experience which
Yes.
counts.
Yes.
Thank you.
And Girja Wag, if she is here in the presentation, she will accept. Because when she was talking about this, the induction of labor, when I asked her about vaginal misoprostol, she also accepts that she has heard like these cases in many incidences.
Yes, madam. Thank you. Thank you very much. Thank you, chairpersons. Thank you,
Thank you, Dr.
everyone.
Supriya. It was a wonderful talk. Thank you
Thank
so
you.
much. So now it's time to invite our next speaker. Dr. Pramila Modi, she wants to give her
very
views.
nice, Supriya. Wonderful. I feel very happy when I see you. I saw you growing. I mean, you are escalating in Foxy now, up and up. Aribato. One thing more, what Dr. P.C. Mahapatra, when he gave his talk yesterday about the same thing, complete perineal tear. So he gave one clue. When you stitch the complete perineal tear, never overlap the tissues. You just approximate. This we should remember, because that time, it is so bad. I think many of us must have experience. So it must be remembered never to overlap.
Yes, madam, and especially if it is a recent perineal tear, then there is not much of problem. But if it is an old perineal tear, it's very important that we properly mobilize the tissues. Because if we don't mobilize and then stitch, then there are chances that it may break and then there may be a fissure
There will be
formation.
tear again.
So thank you so much, Supriya. And now we have a very esteemed speaker, Dr. Charmila Ayu. I don't know how to pronounce.
Ayayu.
So now onwards I'll call Charmila Ayayu. So Ayawu. Okay. Good. So Dr. Charmila is Vice President-elect Foxy. She had been the Chairperson Clinical Research Committee Foxy, ICOG Governing Council member, National Coordinator for UNICEF, Foxy, PCA, ISAR, Gurukul Program, Series Convener, ICOG, WHO South Asia Region, MDSR India member, past Secretary Trichy, Ops and Gynae Society. She has got many accolades to her credit. And it's my privilege to call upon her to talk about a very important subject, that is altered sensorium in the peripartum period. Let's hear from you,
Thank you
Dr.
so
Charmila.
Thank you so much, Abha ma'am. I'd like to thank Alka Pandey ma'am for the opportunity. And when she gave me this topic of altered sensorium, it was a little confusing, because when I went through so many textbooks and guidelines, you don't get anywhere this terminology anywhere. So the scientific committee has actually sat down and thought about such difficult topics for the speakers. So when you talk about altered sensorium, it's actually a diffuse neuronal dysfunction which you have to be thinking of when you have a lady who's got an altered sensorium. Remember, it's because of a decreased supply of glucose and oxygen to the brain. It can be a structural or a non-structural cause, but it's usually a brain disease. The etiologies will be a neurological cause or a toxic metabolic cause. Neurological causes can be structural or non-structural, and the toxic metabolic causes are usually non-structural. There are so many causes for altered sensorium, but when you take a pregnant lady who has come with altered sensorium, to remember 4 conditions which are extremely important. They are puerperal sepsis, preeclampsia, eclampsia, the aftermath of that, postpartum psychosis, and postpartum depression. These 4 P's you remember when you have a lady with altered sensorium. But in our country, please remember malaria also, which can cause an altered sensorium, a severe urinary tract infection which has gone on to urosepsis, acute hepatic derangement, cortical venous thrombosis or a stroke. There can be metabolic abnormalities like a diabetic patient unrecognized was come with ketoacidosis and she has landed up with altered sensorium. It can be the usage of drugs or any sedative drugs which she could have taken. They get referred from hospital to hospital, so you don't know what drugs have been given. And anything can happen in some ladies. That is, we take malaria, sepsis, meningitis, urinary tract infection, hypoxias, hypovolemias, and remember tuberculous meningitis, that's quite common in our country, leptospirosis, scrub typhus, dengue, head injury, alcohol, toxins. Any of that can cause altered sensorium in pregnancy. But whenever you see a patient who has come with altered sensorium, first thing you do is you stabilize her. Then you identify the cause, and for stabilization you use the ABCD approach for management in altered sensorium. Extremely important airway and breathing, because when you correct the hypoxia which is causing a decline in the sensorium, you'll be able to at least bring her back at least partially. And when you do a Glasgow Coma Scale estimation of her neurological condition, when it's less than 8, it's an indication of intubation. But please think over, because in pregnancy there are certain conditions where you can bring out the patient even without an intubation. But with airway management, think about immobilizing the cervical spine when there's a suspicion of injury. Circulation is extremely important to rectify if there's hypotension. But if there's hypertension causing that altered sensorium, remember, there may have been impending herniation, and that's why it has to be treated very immediately in a person who's come with altered sensorium. If there are arrhythmias which are causing hyperperfusion and acute decline in the sensorium, put her on a cardiac monitor, because you need to manage the arrhythmia. The D is for neurological disability assessment, which is extremely important. You can use a Glasgow Coma Scale, or you can use the alert, verbal, painful, unresponsive score, which is used by most of the neurologists. See for the pupil size and reaction, which will tell you about the space occupying lesion. Look at the motor power in the limbs, which will tell you the hemiparesis which is happening in strokes, involuntary movements in the patient, and look for the brainstem reflexes always. And the 5th part is expose the lady. Quick head-to-toe examination, look out for signs of trauma, petechiae, infectious sources such as an indwelling catheter, needle pricks in intravenous drug abusers, or a transdermal drug patch. All that is extremely important for finding out the cause for the altered sensorium. Other measures along with examination is put a quick IV line. As Supriya was saying, IV line is extremely important for any patient in the peripartum period who's having a complication. And while you're managing the ABC of her stabilization, send her blood for investigation, send everything for all. Serum chemistries, a basic hematologics panel, ABG, ammonia, and toxicology screens. And in the peripartum period, look for fever always, and you check her vitals, a pulse rate, a respiratory rate, and a blood pressure. Do a quick SOFA score to find out her neurological assessment as well as the other vital parameters. Check her neurological scale with Glasgow Coma Scale or with the other monitoring systems. Put a pulse oximeter there. Remember to do for a malaria testing, which has come unbooked, and she has been referred to you with altered sensorium, because malaria is very common in a country causing altered sensorium. Look for group B beta streptococcus, that's also very common, and check for the vaginal discharge when she has delivered. And this is what you do in the quick Q-SOFA scale. And when you're examining, look for pallor, look for the size of the uterus, size of the spleen always. And if she's got a fever, do a pervaginal examination, look for uterine tenderness and uterine size. In CNS examination, you will do a neurological examination, which will include neck stiffness, pupils and plantars. Respiratory system, you have to look for consolidation signs, which could have caused the hypoxia. And the bare minimum CNS examination, which is mandatory in a lady with altered sensorium, is mental status examination. That is, the difficulty which has got in communication and recall and the insight into the past and recent events. Cranial nerves have to be examined, motor examination, upper limbs examination. If she is semi-conscious, walking on heel and toes, and the jerk, the knee, ankle and the biceps jerk. There's something called target testing in the peripartum period, because you need to exclude these conditions which are quite common with a high morbidity, and that's malaria. There's something which is less common but also has a high morbidity, that is pyelonephritis or puerperal sepsis. There's something which is less common but has got a low morbidity, and that's postpartum depression. But do not go for a psychiatric diagnosis in a person with an altered sensorium. It is always a diagnosis of exclusion. It's not the first diagnosis. Never make the diagnosis without monitoring her for at least 48 hours with close inpatient observation, and if you've got normal lab reports again and again, but at least ask 2 physicians to examine her before you make a psychiatric diagnosis as a reason for the altered sensorium. Suppose she's got fever and altered sensorium, do not wait for your reports. Rapid institution of broad spectrum antibiotics should be done in the first golden hour. They're very crucial. Do not wait for your reports. Give a dose of ampicillin or ceftriaxone with gentamicin plus metronidazole. Give IV fluids, because sepsis can cause a rapid fall in the intravascular status. 30 ml per kilogram body weight for over 3 hours. And suppose you do not have a facility for checking for malaria, the rapid testing for malaria, and it's not available in the first hour, go ahead and give empirical IV artesunate 2.4 milligram per kilogram body weight. That's mandatory when you have fever and she's got altered sensorium. And what you should not do in altered sensorium in a lady in the peripartum period, do not give sedation, thinking that she's violent or aggressive because she's got a psychological problem. Do not give antipsychotics, give it with caution when the cause of agitation may be actually organic. Do not wait for lab reports before you give the first dose of antibiotics, especially when she's got fever. Do not rely on phone information. Go and see the patient. Don't ask your junior and then manager from the room or from your phone. That's not going to help in a person with altered sensorium. The flow of management will be circulation, airway, breathing, checking for vitals, oxygen to the patient, monitor her, 2 wide bore IV cannula, give normal saline as a bolus 30 ml per kilogram in 3 hours, keep her NPO, because beware of aspiration in a lady who's got altered sensorium. Nurse her in the left lateral position in a dark, quiet, monitored place. But there are certain conditions in the peripartum period which you need to be aware of. And I went through so many studies, I could not get the particular reasons of why altered sensorium happens in the perinatal period. But there's one study which was put in the Journal of Neurosciences in 2021 where they said posterior reversible encephalopathy is a common reason for altered sensorium. The next is cerebral venous thrombosis. The third is postpartum angiopathy, and these are all quite common causes to be identified in the MRI. They have left out a hepatic derangement, which is also quite common causing altered derangement. But the less common etiology which they identified was HELLP syndrome, osmotic demyelination, Apla syndrome, tubercular meningitis, pituitary hyperplasia with hemorrhage, post-ictal edema, cerebellitis, transient splenial lesions, and a change in the old trauma and stroke which is suffered earlier and which is manifested with altered sensorium in the peripartum period. And this condition we need to remember, suppose she is in the altered state of consciousness after a epileptic seizure, she can have an altered sensorium. It can usually last from 5 to 30 minutes, but sometimes it can be quite longer. It's characterized by drowsiness, confusion, nausea, hypertension, headache or migraine, and other disorienting symptoms. But the basic principles of management in eclampsia we need to remember, it's a maternal support of vital functions, control her convulsions and prevent further seizures, correct her hypoxia and acidemia, control her severe hypertension to a safe range, and initiate the process of delivery if she is not delivered. And regarding PRES, it can also manifest with altered mental status. When you do a neuroimaging, you will see cerebral edema affecting the parietal and occipital lobes of the brain. There are two mechanisms proposed for PRES, and that is it may be vasogenic or vasospasm. And when these manifestations you see clinically and neurological in the imaging will all reverse once you have controlled a hypertension and treated a seizures. It's not usually it does not go on later into the postpartum period. And the next condition you need to remember in the peripartum period is cerebral venous thrombosis, which can manifest with headache, focal deficit, seizures, papilledema, impaired consciousness, and sometimes even coma. And remember, in our country, it's very common because of the hypercoagulable state which our women are, because they do not drink water in the postpartum period, particularly in Tamil Nadu. They say that is a part of the recovering from the delivery process, and they do not give enough fluids, and they also give a high fatty diet. They keep on giving that balls of ghee and this thing, and that they say contributes to a hypercoagulable state, can contribute to cerebral venous thrombosis. And the next condition is reversible cerebral vasoconstriction syndrome, and this is a narrowing of the arteries of the brain. Here also the treatment is similar to PRES, where you control her hypertension, give her anti-epileptic medication, and keep her on a long-term neurological follow-up. The most important condition which I've seen in many of our cases is acute fatty liver of pregnancy manifesting as an altered mental status. Remember, 91 to 100% of patients with acute fatty liver can manifest with an altered sensorium, and they will have an abnormal liver test, renal function test, and coagulation test. And remember that very low serum glucose, which happens in AFLP, is a contributing factor of our altered sensorium. And management in AFLP is the core initial lab testing which you will do, immediately transfer her to a tertiary cancer center, aggressively correct her concept to coagulopathy, and most of the times you can save her. The next condition you need to remember for peripartum altered sensorium is diabetic ketoacidosis. It can happen in type 1 diabetes, but it's also recognized in type 2 as well as gestational diabetes. Remember, when you give the steroids for fetal lung maturity, that may be the reason that she's landed up with a decay. And it can happen even at low levels of 200 milligram per DL, and the signs and symptoms occur usually due to the volume depletion. And remember that the bicarbonate level should be used to diagnose at the decay, and you have to manage it with fluids as well as insulin infusions. Remember, it can lead on to fetal distress and stillbirth, but correction of metabolic acidosis will actually help in a successful fetal resuscitation. There's the condition called pituitary apoplexy. It's a devastating condition which is secondary to a massive increase in the size of the pituitary gland, which can happen without cause in a peripartum patient. And it's because of the high estrogen levels of pregnancy. There can be a sudden hemorrhage or infarction into the pituitary, and this can lead on to gland destruction with serious consequences like acute adrenal insufficiency, circulatory shock, neurological deterioration, and visual loss. And prompt handling of complications will be the management for this condition. Resuscitation should be aimed at early correction of the instability of the hemodynamic system. Fluid electrolyte abnormalities should be corrected. Hormone deficiency should be taken care of, and manage our intracranial hypertension. Sometimes you even need a urgent decompressive pituitary surgery if the patient has got rapidly declining vision and neurological status. It will be a challenging situation to manage, but can be done with multidisciplinary collaboration. Thank you so much. I would just like to conclude with saying that altered mental state is a very common emergency case in casualties. Exact etiology may be unknown. Patients may manifest with vague symptoms, but diagnosis and treatment are highly challenging for emergency physicians, and it's multifold in the peripartum states. It needs extreme vigilance by a multi-speciality team to manage the condition. Thank you so much, Nikhil.
Thank you so much, Dr. Charmila. I can understand how much hard work you must have done to prepare this topic.
Thank you.
It was such a vast topic, and you have done it so well. You have included all the practical points.
Thank you, ma'am.
Like pyelonephritis, any patient who comes in shock with altered mental status, many a times we fail to diagnose. But any acute pyelonephritis, it can come with shock.
Shock also.
So we have to keep these rare conditions also in our mind. And diabetic, I had lost a patient with diabetic ketoacidosis. Nobody diagnosed it. And by the time her random blood sugar came, then it was very high. So it's very important to have these things in our mind, that what are the conditions which can lead to altered sensorium. And of course, in our country, we have to think about tuberculous meningitis and malaria, especially in malaria endemic areas. And sepsis, we all know, we start antibiotics, we do the quick Q-SOFA score, that is okay. But the rare conditions also have to be kept in mind, like HELP, AFLP, all these things have to be kept in mind. Thank you so much. It was a very comprehensive and an excellent presentation.
Thank you.
Thank you so much.
Thank you so much.
After this wonderful session, we have yet another interesting session on updates, latest updates in multiple pregnancy, and we have a wonderful speaker, Dr. Sita Ramamurthy Pal, who's from Kolkata. We all know her. She'll be speaking and giving her latest guidelines on this. She is the chairperson of Fetal Medicine Committee of FOXI. Madam, you're welcome.
Thank you. Thank you, and thank you, Abha ma'am, and the entire POGS team for giving me this opportunity. Had a good, very nice 3 days here, starting from the workshop. So my talk is on latest updates on multiple pregnancy, and this is me for you. So we know that the incidence of multifetal pregnancy is rising with advancing maternal age and ART, but now we are seeing a modest decrease with single embryo transfer. And obviously of all the multiple pregnancies, twins are the most common, and they are increased, they have an increased risk of perinatal morbidity, mortality and neonatal death because of the iatrogenic complications of preterm, growth restriction, especially if they are monochorionics. And obviously we know that whenever a report comes in the first trimester, there is no diagnosis of twins. You have to mention whether it is monochorionic or dichorionic twins, because everything becomes double. The problems increase if it's monochorionic, the miscarriage rate increases 10%, perinatal death is to the range of 4%, fetal growth restriction to the range of 30%, preterm delivery 10%, and major defects also with 4%. So you should not accept a report which says twins. Send the report back and make sure that it is there with an image confirming that this is monochorionic or dichorionic, because the entire management relies and is based on that. When we talk about maternal lifestyles, it is important that we provide a multidisciplinary approach. We have an obstetrician there, a fetal medicine specialist, and a neonatologist who might have to intervene if there is any problem. You need to refer them to dietologists, psychologists as well, if you know the ART pregnancy, and sometimes they need physiotherapists. You need to minimize their hospital visits, because a lot of times they have to stay far away, ART pregnancies with twins. So you must make sure that you combine the antenatal and scan appointments together as much as possible. And here the role of preeclampsia screening, though we talk very widely about in singletons, it remains controversial because of the range of uterine artery Dopplers which may vary in twins, given the insufficient evidence for aspirin and prevention and the high screen positive rate required to achieve a good detection rate. So it is debatable, though we still use it. The latest evidence doesn't say it should be routinely recommended. Now, monitoring fetal health is the most important, because clinically we are not able to do it very well. So it starts from dating to pregnancy with the long list of screening of aneuploidy and abnormalities, preterm birth, and then if it's monochorionic, their complications to deal with. As I said earlier, twin pregnancy should ideally be dated when the crown rump length is between 45 to 84, that is between 11 to 13 weeks of pregnancy. You could be ideally doing a scan in these women earlier on, especially if they are IVF pregnancies, but you must confirm the chorionicity at this time where you're able to do your other parameters as well. Now, it is said that in pregnancies which are conceived spontaneously, the larger of the two CRLs should be used to estimate gestational age. In ART pregnancies, you very well know the date of the pregnancies, but somehow when we tend to do scans, we see that the CRLs are higher. And so it is said nowadays, there is no guideline here, it is said that in ART pregnancies and IVF pregnancies, maybe you use the smaller CRL for dating these pregnancies. And then an ultrasound image demonstrating the chorionicity should always be put with the report, so that even if the patient has gone somewhere else, because by the time you've missed the board for the first trimester, the chorionicity will not be seen. One look at the image, even if the report doesn't say it, one look at the image and you will know what it looks like, whether it is monochorionic or dichorionic. So in dichorionic, you have the typical lambda sign, and in the monochorionic, you have the T sign, where you can identify that this is dichorionic and monochorionic, and this is what you should look for in the image. If it is not possible to determine the chorionicity, we as fetal medicine specialists always do a transvaginal scan. But if it is still not possible, this pregnancy should always be managed as a monochorionic one. Another important point nowadays is we always tend to make a note of the cord insertion of the twins, where it is, and document that, because that has implications in managing these pregnancies and the complications that might arise. And if it is a monochorionic, monoamniotic, it is you look for cord entanglement. So this is a list of how you would look at different things. I'm not going into the details for triplets and everything. What are the types? How many placenta would be there? What are the membranes would be there? They'll share one placenta. It could be different combinations. I'm not going into details. A very, very important thing when you report a pregnancy is labeling the twins. Is where the first twin is, where the second twin is, where, you know, usually up and down in the first trimester, and as you go on in the later trimesters, the fetus takes a position, a longitudinal lie. So fetus 1 is on the maternal left and twin is on the maternal right, because what you're reporting is based on that. Because if you are saying that twin 1 is growth deficient and she's going to another person, and then he looks at twin B as twin A and reports that's normal, so that's going to completely confuse the obstetrician and the patient. So label the twin, draw a figure in this. Even when the mother comes for antenatal checkups, for doing CTGs, we don't know which twin is being monitoring. So you write in the ultrasound report that twin A is on the maternal left, that CTG is put on that, and you're referring to that CTG in that particular twin. So make it a point to write it and document it and draw a figure even in your notes as you are doing as you're doing the reports. Remember a perinatal switch phenomenon, because when you are delivering the patient by cesarean section, the twin 2 might be delivered first, because that is what comes in your line of incision. So make it a point that might not be the actual twin you're referring for. Neonatologists might be aware of that, and so you also be aware of that. Issues with reduction when it is triplets. It's easier when it is trichorionic, triamniotic, because we can put a KCl injection and reduce it to twins. But if it is a monochorionic pair, that is one is dichorionic and the other two is monochorionic, you have to be very careful. We usually reduce the monochorionic pair to a singleton, but you can't do it with KCl. You have to use a laser or radiofrequency ablation. But we see a lot of women coming with DCDA to singletons, whether that is allowed, ethically allowed. This is the irony of IVF. You want more and then you want less. So that is the problem. You know, we should be avoiding these things of reduction of dichorionic to twins or to singletons. Again, a very busy slide, but shows you everything that needs to be done during pregnancy. This is available. This is a recent publication guidelines on twins and triplets that is available. But what it says is that when you screen for aneuploidy, you do pre and post test counseling. You can do your combined screening that is equally efficient like the first trimester, but remember, if there is a vanished twin or if there's been a reduction, you should not use the biochemical markers that will give you a false positive, and that is why use only the NT based scanning, which is done properly and correctly. So with monochorionic twins, because they share the same genetic pair, you have the NT, that is average of NT is taken, and you take an average of the calculated risk. Whereas in dichorionic pairs, remember, the risk is individualized. It is specific for the two twins. When you're doing a biochemistry, it has a lower sensitivity, and that's why it gives you a pseudo risk. That's why it's never done for higher order multiples and when there is a fetal reduction. Also, the quadruple screening is not very effective in twins, so rely on the first trimester. Obviously, if they are seen early, better, and most of your IVF, you will do that. Must remember that monochorionic twins have a higher chance of increased nuchal translucency because of the vascular anastomosis. NIPS does very well in twins. Yes, this is one of the tests where you should be doing NIPS. I think as a first line you could measure, because you are doing a scan very often for these women, and in fact for monochorionic twins it said it performs better than in singletons. Though the median fetal fraction is lower than in singletons, but it has been shown to perform equally effectively. So this was a study in 2019. They said it performs well in twins. So overall, the message is that the sensitivity is around 95%. Though there is a small fetal fraction, it is good, but there is a slightly higher failure rate. If the twins are discordant for anomalies, it is better to avoid. But because if it is screen positive, you must make sure that you have to do amniocentesis. Thank you, madam. You have to do double amniocentesis, because the NIPS will not tell you which fetus is affected. So that is important. Again, for diagnostic problems, we prefer CVS, but amniocentesis is easier, especially if the placenta are fused. And you have to map these fetuses very clearly and label the samples clearly when it is done. When you're screening for structural anomalies, they have to be assessed. So there is a pattern, as I showed the previous slide. In dichorionic twins, you start assessing from the first trimester, then you go on every 4 weeks. Whereas in monochorionics, you see them every 2 weeks, and you look for all the anomalies. You do a cardiac screening. They need a fetal echo, because there is a higher risk of cardiac abnormalities, and there is a higher risk of complications. So dichorionic every 4 weeks, monochorionic every 2 weeks. And here you look for anomalies, and you should have enough time in hand for the scan. With your busy clinic, you can't really rush on with these twins. So you must understand, tell the patients that it will take some time. So pre-counseling is very important, and do a fetal echo for them. This quadrant anomaly depends on the chorionicity. So this was one patient. The upper one was a lady who had a hypoplastic left heart in one and the normal fetus in the other. The other twin was normal. So we did a reduction of the other twin and she went on to term. It was easier because it was a dichorionic twins. This lady had a cleft, had a unilateral talipes. It was again easier because that was the only anomaly diagnosed. So she continued with the pregnancy and needed further treatment. So it's easier if it is dichorionic, but if it is monochorionic, it's important. This lady had a complex cardiac anomaly. We couldn't do anything because we couldn't terminate the fetus, so she decided to continue. We thought if this baby was, would die in utero, again it would be a problem if it's monochorionic, but she got lost to follow up. This patient had an anomaly, so this we did a laser, and the other twin was done with a interstitial, with a laser and was effectively reduced, and she continued with the pregnancy. So it's very sensitive, very issues when it comes to monochorionic. What happens to the other pair? Do they continue with the anomaly or do they terminate there? So counseling plays a very important role. So screening for preterm birth is, again, we know that they're at high risk. Cervical length screening is likely to be a good predictor, but the latest is that benefits of preventive treatment are yet to be ascertained, and therefore the use of routine cervical length measurements is still under debate. Do not use fetal fibronectin. All these non-parameters like bed rest, progesterone, circulars, they're all debatable, so we don't know where we stand in terms of preterm delivery. But yes, 2.5 millimeter would be the cutoff, and we continue to still do that. For FGR, there is a thing that by using singleton charts, you might be underdiagnosing the FGR. So twin-specific charts have been proposed, and they are being used in the UK. So that is what we are looking for in the future, where we have twin-specific charts, so they can pick up these twins who had a higher risk of FGR. And in amniotic fluid assessment, you should be doing only deepest vertical pool, and obviously you cannot do the AFI for multiple pregnancy. So here the cord insertion is very important, as I said earlier, because if there is a well-element cord incision where the cord inserts into the membranes, these are the patients, these are the twins who will be at higher risk of complications than the normal twins. There is an international consensus about growth restriction that is the similar for singletons, where there is an expected fetal weight is less than the third centile, or for monochorionics, and if there's a discordance of 25%, but the 25% is again debatable. You can come up to 10% in dichorionics and 10% in monochorionics and 15% to dichorionics. So we have to watch the space for that. For as of now, it is 25% discordance. So again, when the report is mentioned, look at the weight discordance. Even if one fetus is less than the 10th centile, or if the growth discordance is more than 25%, you must be on the lookout for growth restriction or monitor these fetuses more accurately. So referral to a tertiary center if there's a growth discordance. And monochorionic, it depends upon the umbilical artery velocity, so that's a different picture altogether. I'm not going into the details, and because it is monochorionic, if one fetus is very growth restricted, you have options of selectively reducing them by different methods, as I said earlier. So this is according to the umbilical artery flow, which divides into stage 1, then 2A and B, and subsequently. What are the complications specific to monochorionics like TTTS, TRAPS, and single uterine demise? A thing important to note in monochorionic twins, when you have a Leica discrepancy, if it is normal and oligo, that means it could be an anomalous fetus with growth restriction. If it is normal and poly, you have to rule out anomalies. Anywhere there is polyhydramnios, think of anomalies. But if it is poly, only then, that is one sac has oligohydramnios, the other has polyhydramnios, then you think of TTTS, and the deepest vertical pool is what you measure. If it's less than 2, it's oligo. If it's more than 2, it's 8 centimeters. If it's more than 8, it is polyhydramnios. Some people have said that early prediction of TTTS can be done. The CRL has a low predictive value, but the NT combined with the ductus venosus has the highest relative risk of 21, and so you can sometimes predict these women who are going into TTTS. So in TTTS, in stage 1, it is expectant management, but depending on the stages, sometimes if it's very late, we can't do anything much. Twin anemia polycythemia sequence, it is usually seen as a case of post-laser complication for monochorionics, again divided into stages, and depending on what the stages, we can offer the treatment as early delivery, laser ablation, or combined IUT. So you have to offer them weekly ultrasound monitoring from 16 weeks or from when you have done the laser for TTTS. A single IUD is a very important complication because if it is occurring in monochorionic, the death of the co-twin can happen in 15% and a neurodevelopment impairment of the other surviving twin is up to the range of 30%. So you should be ideally, if the death has already occurred, the damage is already done. So if one twin has died, you should not immediately deliver because the damage is already done. If you can predict the death before and then deliver, that's what makes the significance. If the death has already occurred, you should ideally be doing an MRI 4 weeks after the twin to see if there is any damage in the other twin. But just delivering at that point, you're going to put the other twin at equal risk because whatever it is, you're adding prematurity to that. Trap sequence, I'm not going into the details. So the time and mode of delivery is DCTA 38 weeks, monochorionic uncomplicated 37 weeks. For obviously a monochorionic, monoamniotic twins, it's 34 weeks. If it's TCTA triplets, if some people would tend to continue, it's 36 weeks. Continuous intrapartum monitoring is necessary with dual channel CTGs and consider vaginal birth as not for cesarean section of second baby not achieved within 20 minutes. Important in third stage, you have to do an active management with blood availability. Recently, I saw a case when she was dichorionic twins. One twin, she miscarried, the cervix opened, she miscarried, and then the cervix has closed. And I scanned her 4 weeks after the first twin has miscarried because she was determined to continue the pregnancy. The other twin is going on fine. So all the obstetricians told her, no, you have to abort this pregnancy, this will not stay. She, as she was a doctor herself, she continued the pregnancy, and as of now, the pregnancy is still continuing. So strange are the ways of nature, you have to sometimes let it go with that. Neonatal issues are important. So perinatal outcomes have improved in the last 2 decades. Invasive interventions have really improved the monochorionic complications, and we have better take-home baby rates. Improved antenatal care pathways and advancements have really done a good bit of deal. So multiple pregnancies at high risk, detect the antenatal risk factors, improve your antenatal care with multidisciplinary approach, and please avoid iatrogenic prematurity. Thank you so much.
Thank you, Dr. Sita. It was a very comprehensive presentation. Again, a very vast subject, and you have dealt everything so well, right from screening for aneuploidy, for PTL, for FGR. It was wonderful, when to terminate, how to monitor these patients after death of a co-twin. I think all the things were explained very well. Just stay back, I think we'll have a picture with the chairpersons and the speakers. Charmila, please come up. Supriya, come up. Next section,
Nikhil.
As Dr. Sita has finished 1 minute before time as well, so we could have this on time. Thank you so much. But now I'm getting a little worried because I don't want to be delayed, as we also have our first speaker, Dr. Basab, on the stage. I would like to call the chairpersons to please. Can I request the chairpersons to please join us? Can we have Dr. Shobha Rani Sinha, Dr. Ranjana Sinha to please join us as the chairperson? Our first speaker is Dr. Basab Mukherjee, sir. He's already here. And the gentleman on the podium is not Basab, he's actually Mukherjee.
So, moving ahead to a very important session where we have Foxy stalwarts speaking. We have first speaker is immediate past Vice President Foxy, Dr. Basab Mukherjee, sir, who has also been the organizing secretary of the wonderful AICOG 2023. And sir's topic is vaginal microbiomes and adverse pregnancy outcome. Sir, the stage is yours.
Thank you very much, respected chairpersons. It's always a pleasure to be in Patna, this time under the leadership of Dr. Alka Pandey, Dr. Vinita, Dr. Supriya, and the lovely team of POGS. Vaginal microbiome and adverse pregnancy outcome. The sections of this talk would essentially deal with microbiome, the concept. I think some of you would be familiar with microbiome. Over the last year and a half or the last couple of years, there has been talks on this subject. Dysbiosis and adverse pregnancy, reproductive outcome. So what are the problems of dysbiosis? That's something which we would like to discuss. Probiotics as a therapy. Probiotics and prebiotics and symbiotics, we have heard enough, but how does that fit into the entire gamut of things? And probiotics for adverse pregnancy outcome. Do really probiotics make a difference when you talk about dysbiosis caused by adverse pregnancy outcomes? The human microbiome is something which you will have more discussion in the years to come. They may be in the form of seminars, they may be in the form of standalone symposiums, but maybe there may be a conference on microbiome also, maybe in the next 5 to 10 years. The human microbiome is a treasure trove waiting to be unlocked, and there's so much of information that we are getting on this subject. They're writing books on it, Human Microbes, the Power Within, Health, Healing, and Beyond. So what is microbiome? It's a collection of 100 trillion microbial organisms that exist in and on our bodies and play a vital role in our health, protecting us against disease and boosting our immune system and even helping us to digest our food. They also happen to synthesize vitamins like B, B12, K, thiamine, riboflavin, and their dysfunction, among other things, is also associated with autoimmune diseases like diabetes, rheumatoid arthritis, muscular dystrophy, multiple sclerosis, and fibromyalgia. So microbiome is something which is an emerging science, which you can say what is known is that there are 25 phyla, 2,000 genera, 5,000 species, 80% metagenome mappability, and 316 million genes is what we know about. There are bacteria, fungi, and various other organisms there too. And what is unknown is another large part of it. So whenever we look at our hands, we wash it, we look at hands, how hands are, but on the hands are so much of microbiomes or microorganisms which play a very integral part in our cells, in the health and disease. So what are the impacting factors on microbiome? When we talk about microbiome, you can talk about from your hair to your foot, but at the same time, a lot of focus is on gut microbiome, but we will be talking a little bit on the vaginal microbiome today. And so the factors which can impair or impact the gut microbiome ranges from your diet, from stress, from the medicines you have. You know how antibiotics wipe out microbiomes, so you have AAD, antibiotic associated diarrhea, depending on the geography where you're staying, what the air you're breathing, what food you're having, the life cycle stages. At different times in life, you can have different sets of microorganisms in your body, the very birthing process and infant feeding methods. So the first question which comes to our mind is how are microbiomes first formed? The uterus is a sterile environment, more or less. So how does, after a baby being born, how does the microbiome establish? And that's what's being shown here. So in pregnancy, there may be some amount of colonization, but most of it happens during the time of delivery. And so that's why sometimes you think that a vaginal delivery is helpful, because the very fact that the baby's mouth touches the vagina, the baby ingests a lot of microbacteria there, and a lot of this is something which makes his or her makeup, which goes on throughout her life cycle and modifies different disease and health factors. So the skin microflora again later, when the baby is breastfeeding, the mother's oral microflora if she kisses the baby. So all those things keep on getting into the baby's system, and usually it takes 2 to 3 years of life before the microbiome of one particular human being is established. So this is a hot topic for research. I've already said that we would be having seminars and more discussion in this in the days to come. And this is just an example of how much of publishing literature is expanding in this field. Coming to vaginal microbiome, it's an intricate and dynamic microecosystem that constantly undergoes fluctuations during the female menstrual cycle and the entire life. So part of it is, of course, because of the estrogen in the reproductive years between 10 to 50, women undergo different changes. So that is one of the aspects that. Also the fact about, we know that various lifestyle things, your intercourse and the pregnancy, and all of that does play a role in the vaginal microbiome. Even they say constant douching, which we say is not a good thing. Washing the vagina or trying to clean it would be washing off your good bacteria, and that is harmful. One thing which we keep on talking in our school and college awareness programs. So the vagina houses a complex microbial community that subsists in a symbiotic relationship with the host. So what they keep on saying is that this microbiome, the microorganisms are dividing at a very rapid rate, very similar to the mucosal cells, and part of the genes of the microorganisms become a part of the gene of you. So you are not yourself, you are yourself and your microbiome. So the microbiome or the bacteria which you possess in your body is a part of you, and it's a system that you grow up with. So the indigenous environment, microorganisms and the genomes constitute the entire habitat known as a vaginal microbiome, which is not a constant thing, it keeps on changing is what we are saying. So the normal vaginal flora, as we know when we talk about white discharge PV and we talk about bacterial vaginosis, is lactobacillus predominant in 95% cases, and that is there's a ratio of anaerobes to aerobes which keep on changing, and if there are more anaerobes, we know there's a more chance of bacterial vaginosis and infections, and that is sometimes happens. There is hydrogen peroxide producing bacteria which is present, which is a potent natural microbicide and helps in maintaining the vaginal pH. So now comes the factors influencing vaginal microbiome. As we already said, that the dynamic equilibrium can be altered by environment factors and external influences, namely antibiotics, vaginal hygiene, sexual intercourse and hormone therapy. And once this balance is altered, then you have problems, and this is what we're going to talk about, the dysbiosis happening in the vaginal microbiome. So how does this affect pregnancy? What adverse effects in pregnancy can you have because of dysbiosis in the vaginal microbiome? Well, there are normally there is a lot of changes which happen during pregnancy, and this is the immunological, endocrinological and metabolical changes which have significant alterations in the microbiome which normally take place. And now which a woman, if susceptible to genital tract infections, can have adverse pregnancy outcomes. A lot of it goes back to your infection and inflammation etiologies, and those include preterm birth and other pregnancy complications. So dysbiosis in pregnancy has been associated with miscarriage, premature birth, PPROM, PROM, preeclampsia, FGR, low birth weights, and sepsis, and neonatal sepsis too. So there are a gamut of diseases, again rotating around infection and inflammation, which are more predisposed to a pregnant woman if she has an altered vaginal microbiome, something which we do not always think about. We thought that she may have got infection from somewhere, but we always do not know the thing. So ascending intrauterine infection through an abnormal vaginal microbiome, ascending intrauterine infection, sometimes it is UTI, sometimes it is a vaginal infection. That leads to bacterial colonization of the decidua, fetal membranes, amniotic cavity, release of pro-inflammatory cytokines, prostaglandins, MMPs, and that would lead to uterine contraction, cervical relaxation, and formally delivery. So dysbiosis and preterm birth, this is one which is the most studied in pregnancy. So the etiology of preterm birth, as we know, is multifactorial. We know that anything which is good to reduce preterm birth is worth giving it a hearing, but it has been estimated that 1/3 is due to infection and inflammation, and if there is some way where we can change the vaginal microbiome so that this chance is less, it is definitely worth giving it a thought. So 40% of preterm birth, 80% of early preterm birth less than 28 weeks would be related or associated with some infection, inflammation combo. And bacterial vaginosis is also an independent factor. Studies have already also shown that besides pregnancy, in subfertility there is an association with dysbiosis, and adverse vaginal dysbiosis in subfertility has adverse pregnancy outcomes, especially in women going having IVF, and this could be linked to the implantation failure. And that is something where again a lot of people are trying probiotics or some other intervention before ART procedure with some variable amount of results. So here this is a study on the evidence that endometrial microbiota has on effect of implantation success and failure. The presence of a non-lactobacilli dominated microbiota in a receptive endometrium was associated with a significant decrease in implantation rate, pregnancy, ongoing pregnancy, live birth rates. So different bacterial communities were detected between the uterine cavity and the vagina, and there is some evidence to suggest that if you give probiotics, then it may make a difference. So coming a little bit to probiotics, how does that fit into the scheme of things? The term probiotic is derived from the Greek meaning probios, so that's for life. And at present it is defined as life microorganisms which, when administered in adequate amounts, confer a health benefit to the host. In current times, they seem to have a promising role in either preventing an infection or shortening its duration, and we still are very early in the research stage, and important to understand. But the idea of probiotics is not new. It goes back many years. So Hippocrates in Greece has said, death sits in the bowels. A bad digestion is the root of all evil. So they understood that there's something in the digestive system which goes wrong, can make you terribly sick. Even in Ayurveda, more than 3,000 years ago, they used to mention buttermilk and yogurt, which is actually essentially a probiotic, and one who takes it daily does not suffer from diseases, and diseases cured by takra do not recur, just like amrita for the gods, takra is to humans. So they understood the importance of buttermilk. Again, that comes to the probiotic concept quite early in the thing. The other thing which we were talking about is how does oral probiotics, when you give an oral probiotic, how does it go and colonize the vagina? And that's very clearly understood, that it breaks down in the bowel, goes through the digestive system, ascends through the perineum, and then reaches the vagina where it colonizes it. And probiotic in preterm birth, now coming to whether giving probiotics would make a difference and reduce the risk of preterm birth or reduce the chances. Well, there are studies on that. And protective action of probiotics against preterm birth starts preliminary by avoiding the onset of bacterial vaginosis. That is one of the times. Again, BV will increase once there's dysbiosis. And lactobacilli can prevent the degradation of cervical tissue by inhibiting the colonization of pathogenic bacteria, that is what we know. And release of matrix metalloproteinase 8 reduces the ascension of pathogens to uterine region and microbial invasion of the amniotic cavity. So there is some understanding that probiotics in preterm birth, this is just one study in 2020 published, where they said the intake of probiotics can reduce the risk of preterm labor by 18%. Too early to come to great conclusions, but this is the prospective observation cohort study on the effect of probiotic, some milk product, on the risk of preterm delivery in 37,000 women, and the authors came to the conclusion that their risk was decreased by 21%. And this is the PIP study, where double-blind randomized controlled study where the use of probiotics reduce maternal GDM, GBS, bacterial vaginosis, postnatal anxiety, depression, and neonatal atopic asthma and eczema. So a Cochrane review of 2016 shows an 81% reduction in vaginal infections. So infections, yes, but how much does this make a difference in reduction of preterm labor incidence is something which hasn't been mentioned. Pregnancy outcomes in women taking probiotics or prebiotics, a systemic review and meta-analysis. It neither decreased nor increased the risk of preterm birth in this study, which was there. So again, as I said, there needs to be more things which need to be done. Summarizing, a more complete understanding of the role of reproductive microbiome, is that one of the words which you can use, which would include the microorganisms in the vagina, in the uterine lining, and possibly in the tubes, promises improvements to fertility treatment as more you have more IVF success rates. About preterm birth, where does that fit in, is something which we really have to look into and see. It is a new frontier, and the currently accumulated knowledge will propel the discovery of new treatment solutions and protocols, is what we think in the future. Dysbiosis in vaginal microbiota, also induced by conditions like polycystic ovary, endometriosis, PID, BV, and urogenital infections, can be associated with, as we said in the IVF segment, it's bad oocyte, embryo quality, low implantation rates, and in the obstetric segment, it would be miscarriages, preterm birth, PROM, and neonatal morbidity. Thank you. Thank you very much.
Thank you, Dr. Basab Mukherjee, for your excellent presentation on vaginal microbiomes and adverse pregnancy outcome. Really, a time has come to pay attention to this topic, vaginal microbiomes, and I think in coming days, it will be more on research.
So thank you, sir, for your excellent presentation. I think you would agree with me that nowadays many companies are promoting various vaginal washes, and that should be discouraged. As you said, that normal water is enough to wash vagina. So regular use of vaginal washes should be discouraged. Yeah. And nowadays in IVF pregnancies, IVF specialists are using these prebiotics and probiotics for a long period, and I think it helps in the outcome. Yeah. Thank you very much.
I think we have to watch this space. I think douching generally is bad. So whenever you're washing in perennial hygiene, it has to be from externally. So whenever it's internally, that's not a good idea. So that's the general advice which goes. So all the washes are for external use and not for internal use. I think that's it.
Okay. Thank you, sir. And now I would like to invite another Foxy stalwart, Madam J.M. Kanan. Thank you very much, Madam. On our request, you have come all the way from Chennai to Trichy, yeah. Sorry, ma'am. Trichy, and you are a great teacher. So kindly enlighten us on the topic, acute kidney injury in pregnancy, which is a cause of maternal mortality and fetal loss if it occurs during pregnancies.
Thank you. Thank you. Respected chairpersons and the august members in the floor. Thank you very much for this nice opportunity. The acute kidney injury, like what we say injury, nobody hits at the kidney. It is some other complication of a serious illness that hits the injury, that hits the kidney. The renal failure has been defined with so many other details, but one has to note very specifically it doesn't occur just like that in a few minutes or seconds or hours even. It takes about a few days to occur, and it is mostly seen in people who are hospitalized. As the details have been given in these things, that the time is short, Nikhil will hit on me if I stay for more than 30 seconds extra. So I would like to put you on only 3 important details: the volume of the urine that is sent out, the BUN and the creatinine, which are going to be very specific for your diagnosis of any renal shutdown, especially in obstetrics. Anatomically, you can look for an expanded kidney with a dilated system, more on the right side than on the left side, and a physiological change of creatinine clearance, blood urea nitrogen, and creatinine anything more by 0.3 milligram in 48 hours. Prakash is one person who has been working on this for 35 years, ever since Apollo Chennai started, 1982. Professor Mani's assistant. Professor Mani is one of the august known persons of nephrology in India, and to say, when M.G. Ramachandran was sick, when somebody called somebody from Japan, they asked, has Mani seen this case? Such a big hospital with 35 years of experience, and he has put out saying the increase in incidence is noted with 3,100 cases from for 426, 8 times increase. Is it because the kidney injury is more happening? No. It is because of the high rates of detection which are going on with more number of deliveries in the hospitals, and we are seeing more high risk pregnancies with comorbidities like diabetes going up nearly 50%, 60% in pregnancies, and the advanced maternal age automatically getting added. The renal shutdown in labor was another topic which was also suggested to me by your Alka. When she gave me this topic in they say Pune, I was thinking, is she kidding me? Because there is no urine in just 6 to 8 hours. In 6 to 8 hours or 12 hours in the first stage of labor, or even 4 to 6 hours in the second stage of labor. Nobody is going to look at urine output in the first stage of labor too much or in the second stage of labor. And it is not a significant specifically done. Why madam is saying like this? Yes, I started looking at those cases who are having problems in obstetrics also in labor. I'll come out with those cases also. The normal etiology, pathology, physiology, diagnosis, all these things you all see in all obstetric books and in kidney books. I am not going here because all of you are postgraduates who have passed this stage of degree. Now let me give you some visuals and explanations. So, it is a stony hard uterus admitted at 30 weeks of pregnancy, and there is no output on catheter in the emergency room. And the vitals show hypovolemic status. What is the diagnosis? It is AKI with accidental hemorrhage or just AKI alone. As obstetrician, we will take the urine output not known, we don't know it is 1 hour or 6 hours, but still we take it as AKI, accidental hemorrhage, and start treating it, because we all know very well, once we treat accidental hemorrhage, there is good chance of recovery of this urine output. At the same time, kindly note that this patient had normal renal parameters, except that she had no urine. Parameters were normal, nephrologist was kept at the side, hematologist was also kept at the sides, and no, in these cases we cannot manage her in a purely obstetric unit team, and do not treat this sort of patients in a primary health center, even in a CHC center as per the Government of India guidelines also. Please give her a multi-specialty care, and you all know what the care should be given, and she comes out. Now look at the second case, very interesting. For me it is interesting till date, but for you, tell me at the end. Preeclamptic, diabetic, under insulin, antihypertensive, 36 weeks. 36 years, 32 weeks. She does a very good home monitoring. On a Sunday morning, 9 o'clock, she records 160, 100. She calls the doctor. Doctor wants her to come to the hospital. Promptly at 9 a.m., she lands the hospital with 180, 120 blood pressure, no proteinuria. In the last 2 days, she has gained 5 kg weight. She passes urine. Obstetric cardio care, everything was given to her in that obstetric unit on a Sunday. Stabilizes her blood pressure. So, the junior MD-DGO gave a sigh of relief. Thought that we will do electively something tomorrow. Blood urea, nitrogen, creatinine, everything normal. 4 hours later, BP 120, 220, 140. Who will keep quiet? Sunday afternoon, pregnancy terminated. Because it's a hospital with lot of obstetric unit, care, when she had a PPH, an hour later, Bakri balloon was promptly put in, and she had 2 units of blood transfusion, returned to a better stage. As ABG and parameters were being looked at, in spite of the fact her blood pressure, everything was normal and she looked normal, by 7 p.m., serum potassium is 11.8 millimoles. Happy? She is now, is she a case of kidney injury, or is she just a case of diabetic preeclampsia? In this case, the severe metabolic and bleeding status has resulted on kidney problem of not excreting the potassium. She was immediately shifted to another ICU tertiary unit. Within 6 hours, her potassium was brought back to normal. She was returned back to the obstetric unit next day, and she was normally discharged after 48 hours as like any other patient. Now, in these patients you have to know 15% of preeclamptics can have AKI. The risk of maternal death is too much. The KDIGO AKI stress says if you have detected at the first stage, as we have done in this, recovery is 94%. If you have not detected, you can still recover at the third stage 67%, but with a 30% mortality. So history of hypertension in a previous pregnancy or in the present pregnancy is a strong indicator of AKI. The renal parameters all being looked may be normal, but till date serum creatinine is the only level taken up with just more by 48 hours 0.3 milligram. You have to treat it as renal injury only. The identification with serum creatinine is kept days even by KDIGO criteria is being talked about. Apart from all the causes which we know, abruption, preeclampsia, hemorrhage, septic abortion, febrile sepsis, women with previously normal kidneys can also show renal problems in the next pregnancy. The Nephrons 2023 also talks about all the recent involvements in AKI, renal transplant cases, under dialysis patients, patients on COX-2 inhibitors, rheumatoid arthritis cases, and autoimmune disorders, which are the new inclusions of AKI etiology in obstetrics, as we are seeing more cases. Earlier there was a reference about hyperemesis gravidarum case, which is, it leads to a lot of serious illness in the previous thing. Madam, I will give you a case of hyperemesis causing this problem also, and this patient with all this pre-renal, renal, post-renal, which are fitting in with all our obstetric causes, which we know very well, and this dynamic stages, only in the second stage we get all the problem, first stage we do not look at eating, and we also have a normal pregnancy going in for an AKI. Look at these patients. Robson's 9 criteria underwent a cesarean section. Madam, can I have a time please for me? Dr. Yasodhara? It is disturbing for me. Case 3 is a Robson's criteria cesarean for Robson number 9. On the table just a few ml of urine. Then 2 hours later with 1500 ml they thought she will recover her. By 2 hours it was only 40 ml. So they were on heels and they gave IV fluids as per the guidelines of 60 kilogram weight of the patient, and the patient was given IV fluids accordingly. Another 2 hours went off, furosemide given. Furosemide is normally expected to give you 100 to 150 ml per hour, which did not occur. So at the end of 4 hours, the patient was found to be renal failure, normal patient. She was shifted to the ICU with nephrologist, prompt dialysis, gave her recovery, but no specific reason was found out. So that is why nowadays we say every normal pregnancy is also a bullet. We have to take it up properly, and we have to see that urine output is always kept it up, because pregnancy itself can cause 50% renal damage with all the post-renal and intrarenal factors which are there. The work done up in all these cases have to be with all the general parameters. Are we going to think of a biopsy or other things? Nephrostomy is a question which has to be left to the nephrologist only. Previously, Asha madam was talking about worrying about pyelonephritis causing brain damage. Yes, madam, I give you explanation. The renal injury leads on to circulatory inflammatory mediators, oxidative stress increased, and the impairment of the blood-brain barrier, resulting neuroinflammation and neurocognitive impairment. Am I giving just like that? No, I took a case from Teni, from Professor Shantirani courtesy, and this is a 24 weeks woman that hyperemesis caused IUD. So promptly they induced labor and they delivered the fetus within a day. Happy in the evening. Next day morning the PG calls and says there is no urine output. Immediately, because it's a multi-speciality medical college, they went on with dialysis. 24 dialysis was done in about 4 or 5 days. Still, patient recovered, okay, but she started looking at it like this, the look that she's given. She refused to answer anything. It was a pre-Deepavali day down south. So at Teni, which is like Aurangabad from Patna, they could not do an MRI. So they immediately shifted the patient to Madurai, like Patna. At Madurai, she was diagnosed as post-renal encephalopathy. 45 days of hospitalization, stormy period, went home, delivered another child subsequently, no complications. So this is one case, because when you were saying about it, I thought I should correlate this case with it. So renal encephalopathy is nowadays becoming a known factor, and we have to. Recovery from kidney injury may even take 2 to 3 weeks longer. It is not expected to be within a week alone. Management is to keep the blood urea level higher up, at least within 45 to 60. Minimize the fluid shift, because the fetal well-being is very much required. If you are thinking of a preterm delivery, please administer corticosteroids liberally in these patients and have a fetal medicine expense also. Renal biopsy or a nephrostomy, please leave it to the physician or nephrologist. There is nothing wrong in doing this thing also. Yes, I am finishing it up. Okay. Take home pulse is diagnose the AKA, which is challenging. Standard criteria are yet not available. Timely diagnosis is instrumental. Specific treatment with prompt delivery and appropriate referral is required. Multidisciplinary management is the order of the day for you, not to keep her in a standalone obstetric unit, however big the obstetric unit may be. Thank you very much.
Thank you, ma'am. Your presentation was very nice, and it helps us how we can prevent morbidity and mortality both. Thank you very much.
So, thank you very much, ma'am. You have taken us to the real labor room scenarios where we are in perplexing situation. So, early diagnosis, early suspicion, early diagnosis, and aggressive management, I think, is with the help of a nephrologist, is it should be the key management. Thank you very much, madam, for enlightening us. And to invite our next speaker is Dr. Mala Srivastav, who will be talking on shoulder dystocia. Madam is a senior consultant and unit head at Sir Gangaram Hospital, and madam is a very known name in AOGD and ISOPARB and NARCHI as well. Madam has held many coveted positions in many organizations. Madam, please, the stage is yours.
I thank the chairpersons for the kind introduction, and I also thank Dr. Meena Samant and Dr. Supriya for having me here, and Dr. Pandey for having me here. Good morning, everyone. Today I am going to speak about shoulder dystocia. Shoulder dystocia refers to difficulty in delivery of the fetal shoulders. The incidence is 0.2 to 3% of births, but it can be a devastating obstetric emergency. The goal of management is to prevent fetal asphyxia while avoiding physical injuries. We don't want Erb's palsy or bone fractures in our fetus. The overall incidence of shoulder dystocia varies based on the fetal weight. It's a bad situation, but we have to make the best of it. Shoulder dystocia can be defined as a failure of the shoulders to spontaneously traverse the pelvis after delivery of the fetal head. In practice, actually what diagnosis of shoulder dystocia is subjective. It has to be considered when routine practice of gentle downward traction of the fetal head fails to accomplish delivery. What is the pathophysiology? There is increased bisacromial diameter, mismatch between the fetal size and maternal pelvic cavity, and there is a positional variation, vertical rather than oblique orientation of the shoulders. Fetal macrosomia is the most significant risk factor for shoulder. Other risk factors are diabetes, gestational diabetes, previous history of shoulder dystocia, operative vaginal delivery, especially with the use of the vacuum. The head is delivered, but the shoulder gets stuck. Other risk factors include maternal obesity, excessive maternal weight gain, labor dysfunction, as well as certain conflicting situations. So what are the maternal consequences? PPH and also increased risk of 3rd and 4th degree laceration. And if certain heroic maneuvers are done, that is Zavanelli's maneuver, there is a significant maternal morbidity. Fetal consequences, herbs injury, brachial plexus injuries, fetal clavicular humeral fractures, hypoxic ischemic encephalopathic syndrome, and even fetal death. Most of the brachial plexus injuries are transient and they resolve with time and physical therapy, but sometimes they become permanent. Is the prevalence of shoulder dystocia becoming more, or we are diagnosing them more, especially because of high birth weight, because the incidence of maternal obesity and diabetes is going up and up? So again, what are the risk factors? Maternal risk factors are DOPE, that is diabetes, obesity, post-term delivery, excessive weight gain. Interpartum factors, prolonged second stage of labor, oxytocin induction, mid-forceps or vacuum delivery. And of course, if there is an abnormal pelvic cavity, gestational diabetes, previous shoulder dystocia, short stitches, and suspected macrosomia. How do you diagnose? There is inadequate spontaneous restitution, fetal face becomes plethoric, and there is a turtle sign. That means that there is a recoiling of the head back. Management, helper mnemonic. Help, call for additional assistance, evaluate for episiotomy, legs are hyperflexed. Mac Roberts maneuver, give suprapubic pressure, do internal rotation, remove the posterior arm, roll the patient to the hands or knees. So, avoid 5P. Don't panic, don't pull, don't push, don't put pressure on the fundus, and don't do pivoting. Call for help. Clear infant's mouth and nose. Once diagnosis is made, you have to have your team in place. Maneuvers are typically divided into first line maneuver and second line maneuvers. First line maneuver is what you do, try to do gentle pressure on the fetal vertex in a dorsal direction and will try to move the posterior fetal shoulder deeper into the pelvic hollow, resulting in easy delivery of the anterior shoulder. But do not do excessive angulation. More than 45 degree has to be avoided, otherwise you will land up into the brachial plexus injuries. First line maneuver is Macrobots maneuver. This is done when you do hyperflexion of the hip joint towards so that the thighs are towards the abdomen. This will straighten the maternal sacrum on the lumbar spine. Suprapubic pressure is given. The goal of suprapubic pressure is to decrease the fetal bisacromial diameter by adducting the anterior fetal shoulder. Pressure is applied to the suprapubic area in a downward fashion so that the shoulder comes towards the fetal chest and the diameter is decreased. So you can see here, once you do the hyperflexion or the macrobots position, there is a straightening of the sacrum in alignment with the lumbar spine, and you get more and more space, and then you give suprapubic pressure, so the anterior shoulder is pushed towards the fetal chest and the bisacromial diameter is slightly reduced, and then it can help in the delivery of the fetus. The second leg maneuvers which are rarely need to be done, of course, is Rubin's maneuver, which is performed by placing a hand into the vagina and applying pressure on the posterior aspect of the most accessible fetal shoulder towards the fetal chest. This will lead to the adduction of the fetal shoulder, which will then allow the anterior shoulder to rotate and deliver from behind the pubic bone, which is impacted. And the other is Wood's corkscrew maneuver. This is opposite to the Rubin's maneuver. The obstetrician places a hand on the anterior aspect of the posterior fetal shoulder and rotates the shoulder towards the fetal back. The goal is to attempt to rotate the fetal shoulder by 180 degree. This allows the fetus to descend while the rotation is occurring. You can see the Rubin's technique, also known as reverse Wood's screw maneuver. Rubin's technique requires the practitioner to apply pressure on the posterior aspect of the posterior shoulder, and you rotate it by 180 degree. Anteriorly, if the anterior shoulder is stuck at above the symphysis pubis, once you do 180 rotation, then it comes into the sacral hollow and then it is disimpacted and it comes out. And when you do the reverse method, then you are pushing the posterior shoulder toward the anterior part, so that the anterior shoulder comes again in the sacral hollow, it is disimpacted and it is delivered then. Because anteriorly the outlet is deficient. That is why the anterior part of the true pelvis is small, whereas the posterior part is big. So once you make the anterior shoulder posterior, it comes into the sacral hollow and then it is easier to deliver. Next is delivery of the posterior arm. The obstetrician slides a hand along the fetal posterior shoulder and arm, and the fetal forearm or wrist is grasped and swept across the anterior fetal chest to effect the delivery of the posterior arm. Once the posterior shoulder or the posterior arm is delivered, the definitive diameter becomes less by 3 centimeter, and then the delivery of the fetus by the shoulder is easily done. Next comes the Gaskin maneuver. With the patient on her hands and knees, all 4 position, or in a racing start or sprinter position, gentle downward traction is applied to the posterior shoulder, the shoulder against the maternal sacrum, or upward traction is applied on the anterior shoulder, the shoulder against the maternal symphysis. This is the Gaskin maneuver. Next is posterior traction or Mentiglo or posterior axillary string traction. May be especially helpful in situations where the fetal arms are extended. With each method, the assistant should hold the fetal head and flexes it upwards towards the anterior shoulder. Then the obstetrician places their middle finger under the posterior fetal axilla and applies downward and outward traction, which leads to the delivery of the posterior shoulder and is followed by the delivery of the posterior arm. You can also use sling traction, posterior axilla sling traction. A suction catheter or firm urinary catheter is used as a sling. Traction is applied to the sling to deliver the posterior shoulders followed by the arm. Alternatively, the sling can be used to rotate the shoulders by applying lateral traction towards the baby's back while the other hand is placed on the anterior shoulder, putting pressure over the fetal chest. Then comes the heroic measures. Believe me, it is very difficult to do it practically. These are very good said theoretically. This intention is to do the clavicular fracture, decrease the bisacromial diameter and then deliver. Disadvantage is difficult to execute, possible injuries to the underlying vascular and pulmonary structures. The other is Zavanelli's maneuver. The fetal head is rotated to its pre-restitution attitude, flexed, elevated up the vagina, and then the delivery is done by the cesarean section. Easily said than done. Then is abdominal rescue. If a cephalic replacement or Zavanelli's maneuver is unsuccessful, a low transverse hysterectomy is performed and the fetal shoulder are manually rotated to an oblique diameter through the transabdominal incision. Once the fetal shoulders are rotated, vaginal delivery is then attempted. Finally is symphysiotomy. With the patient in lithotomy position, Foley's catheter is placed, the urethra is retracted laterally, skin, subcutaneous tissue, incision incised with the scalpel to the level of the symphysis pubis as well as the anterior fibers of the symphysis pubis. Recommended only as a last resort if all the other methods fail. Complications are many if you are doing these heroic measures. Shoulder dystocia is a known risk factor for developing in sometimes causes brachial plexus injury. The incidence is 3 to 17% in the setting of shoulder dystocia diagnosis. There can be phrenic nerve palsy, there can be Horner syndrome, clavicular fracture in 1.7 to 9.5%, humeral fracture, permanent brachial plexus palsy, hypoxic ischemic encephalopathy, and if there is a delay in delivery, there also can occur the death. Etiology of brachial plexopathies. Upper lesions are most common in shoulder dystocia when there is a lesion of the C5 and C6 deficiency, if there is the lateral flexion of the head away from the affected shoulder. Lower lesions are caused by traction of the shoulder in full abduction at the time of delivery, when we are trying to deliver the posterior shoulder by finger or by sling and all that. Total brachial plexopathies are the rarest form of obstetric plexopathies and are caused by severe stretch or avulsion injury. What we have to do, we have to anticipate these conditions. try to avoid delivery if you think there's a patient is obese, there is a cephalopelvic disproportion, if there is fetal macrosomia. We have to anticipate these problems in the antenatal period. But most of the cases occurs in low risk situations when we are not anticipating. So we should know that the shoulder dystocia is an emergency situation in the labor room, and we should know how to deal with it. Appropriate management during the interpartum period is important, so every obstetrician should be aware of the situation and adequate action in the postpartum period to avoid complication as much as possible. Thank you for your patient listening.
Thank you, ma'am, for your wonderful presentation. And
so it is a time for felicitations of all the esteemed speakers. May I invite Dr. Basab Mukherjee, sir, and Dr. Jayam Kanan, ma'am. May I invite also Chair Scientific Committee, Dr. Abha, ma'am, Chairperson Organizing Committee, Dr. Alka Pandey, ma'am, Nibhadi, Dr. Nibha Mohan. And we also have another Vice President Foxy with us, Dr. Yashodhara Pradeep, ma'am. Kindly join. Yeah, and Dr. Meena Samant, President of Patna Society.
At the same time, can I also request Dr. Usha Nidwania, Dr. Renu Rohadgi, Dr.
Do we
Rita
have Dr.
Chakore,
Monica here?
and Dr. Sangeeta Sinha to also join us on the stage.
Dr. Charu and Dr. Supriya.
Thank you so much. With that, as we're moving on to the next one, can I also request Dr. Pramila Modi ma'am to also join us on the dais? Dr. Pramila Modi ma'am, if you could join us on the dais as well. With that, we would like to move to the next session. Thank you. Thank you, speakers. Thank you, chairpersons, and the organizers for keeping it on time. As you can see, our speaker, Dr. Pramila Modi, has also joined us on the stage. She can take the dais. Thank you. मुकुंद प्रेजेंटेशन लाइव कर दे अभी. Thank you. Thank you. With the permissions from the chairperson, can Dr. Pramila get started?
ये करो ये वाला है ना.
Dr. Pramila Modi is right with us, and her CV was on the screen, so you can just...
Good morning. I thank the organizers from my behalf and my co-chairperson for giving me this opportunity to chair this important session on experts talk. I'm sure we are lucky to have such a session, and this session has been very wisely selected, the experts talk, and I'm sure you all will be benefited, and each part of the talk of our experts will be take-home message for all of us. So I first invite Dr. Pramila Modi to talk on challenges in diagnosis and management of accidental hemorrhage. Welcome, madam.
Thank you, Usha. Respected organizing chairperson of Labourcon, the chairpersons of this session, my dear friends, particularly I would like to thank the scientific chair Abha Rani Sinha for selecting such a topic for me, which made me to read a lot. Thank you very much. My topic is challenges in diagnosis and management of accidental hemorrhage. Accidental hemorrhage is a type of antepartum hemorrhage. It is a significant cause of perinatal mortality and maternal mortality. The overall incidence is about 1 in 100 deliveries. Accidental hemorrhage is also called abruptio placentae, is defined as premature separation of normally situated placenta after the 28th week of gestation and before delivery of the fetus. Basically, there are two varieties of accidental hemorrhage. One is a revealed one and another is a concealed one. The concealed one, in which blood collects behind the separated placenta or gets collected in between the membranes and decidua. The collected blood is prevented from coming out of the cervix by the presenting part, which presses on the lower segment. This type is rare. The reveal is a common one. Following separation of the placenta, the blood insinuates downwards between the membranes and decidua. Ultimately, the blood comes out of the cervical canal and thus it becomes revealed. A third variety is a mixed one, in which the picture is also sort of a mixed type. Etiology is unknown, but some factors may be associated, like hypertensive disorders of pregnancy to the tune of 30% due to spasm and degenerative changes in the decidual arterioles. And of course, multiple pregnancy is a very important cause. Trauma, as during performing external cephalic version, can lead to this. Sudden drop of intrauterine pressure as rupture of membranes in polyhydramnios. Deficiency of folate, vitamin C, K and E. Passive condition of uterus is also responsible. Torsion of the uterus and smoking. Coming to the pathogenesis, as I said, there is separation of the placenta. This leads to the retroplacental hemorrhage, and which forms hematoma. This is responsible for all the three types, or you can say two types of the accidental hemorrhage. Down below you can see two pictures of covular uterus, in which the blood really it flows down between the muscle bundles of the myometrium, and the typical color, once you have seen, you will never forget this covular uterus. Coming to the real aspect, that is diagnosis. It's a real challenge to diagnose because multiple of complexities are there. Most of the time, diagnosis can be made by clinical examination only, but no doubt, ideally speaking, it must be confirmed by the diagnostic aids like USG and blood examination. Non-availability of USG, facility for transfusion of blood and blood products, and ideal facility for active management of labor are the major challenges the obstetricians face. Symptoms are acute, constant, and severe abdominal pain, which may be localized or diffused. Dark blackish colored vaginal bleeding, this is quite typical, drains from the retroplacental hematoma. Diminished or cessation of fetal movement is commonly observed, which leads to intrauterine fetal death. On general examination, there are some signs. Patient is usually in shock and it presents with the bleeding which is not proportionate to the the shock is not proportionate to the amount of bleeding due to concealed or revealed hemorrhage. There is over-distension of the uterus, damage of myometrium causing neurogenic shock too. Investigations are very important for diagnosing accidental hemorrhage. Ultrasonography is the most important investigational tool. It detects normally situated placenta with retroplacental hematoma. But let me tell you, many a times it is not visible clearly, so it becomes difficult to find out. It differentiates placenta previa from accidental hemorrhage and signifies the status of fetus. 5 to 10% of accidental hemorrhage are associated with disseminated intravascular coagulation, the dreaded condition we can ever think of. Diagnosis of coagulopathy is essentially a clinical one. Even when the most sophisticated hematological laboratory facilities are available, the time taken to provide the results of detailed coagulation studies limit the value of the presence of a rapidly changing dynamic state. For this reason, one is forced to rely upon regularly performed side room or bedside tests, which is really challenging. Why challenging? One can depend upon this or not. If it do not depend, then the time is passing and the patient will go in deeper shock. So, most important tests are coagulation time, bleeding time, clot lysis test, spontaneous lysis test, blood smear, platelet count, etc. The advantage of these bedside tests are that it can be repeated at hourly intervals or at any time needed when circumstances really it is really to do at hourly intervals or any time needed when circumstances demand, and immediate reassessment of the hemostatic mechanism has to be seen. It is challenging to undertake such rapid tests and proceed according to the management regime to save the patient's life. The purpose of lab coagulation tests is merely to establish the definitive diagnosis, but it is of little subsequent clinical value. However, in every case, experienced hematologists should be summoned to take blood for a full clotting screen. Some profile includes measurement of Kaplan clotting factor, prothrombin time, plasma fibrinogen level, platelet count, and fibrin-fibrinogen degradation product. Now coming to the management, which is the real task. Management is definitely challenging, as the diagnosis was, and different in each case, not the same type. There is no role of conservative treatment in most cases. As soon as the patient is admitted, we come to a clinical scenario type. As soon as the patient is getting admitted in our setup, a thorough examination should be done regarding amount of blood loss and maternal status, fetal maturity, well-being, and whether the onset of labor has started or not. Central venous method of the needle being put, it has to be established to assess blood volume, which is the best guide as said. Adequate blood volume has to be maintained. Arrangements for blood packed cells, fresh frozen plasma, and all blood products should be really ordered for in the meantime when the patient is getting prepared for the operation or normal vaginal delivery. However, Rho negative blood is a safe thing to be given when the true matching blood is not available. It must be kept ready. Hemostasis must be maintained, and let me tell you, nowadays tranexamic acid has come a long way forward even in these cases. Prevention of treatment of early complications like renal and lung shock syndrome, etc., must be taken care of. Like Dr. Jayam Kanan has today just now told about the renal aspect. Blood pressure and pulse monitoring should be done every 15 minutes. It is a big challenge to arrange all the requirements before starting obstetric management. And regarding decision making about when, how, and where to start active management is a much, much bigger challenge. Obstetric management consists of the vaginal delivery, which is favored. Expectant management is, in case of abruptio placentae, is an exception. Amniotomy and oxytocin drip, that means induction, is to be undertaken if bleeding is not severe, with vertex presentation, adequate pelvis, and partially dilated cervix. Advantages of amniotomy are it reduces intrauterine tension and intravasation of the blood between myometrial muscles. It also reduces pain and shock, and definitely it induces labor and improves uterine contractions. Certain indications have been laid down which are also challenging. I mean, where to do, where not to do, and must be performed at the earliest. This is a clue. If you want to really save the woman, the management should be very brisk, and as soon as possible the delivery should be taken. In severe hemorrhage, cesarean section is indicated no matter whether the fetus is dead or alive. Living fetus with labor more than 6 hours have passed with the cervix remaining unfavorable is a definite indication. Failure to progress after amniotomy and oxytocin drip, there is no progress, so must do it. Fetal distress, and of course any other obstetric indications are there. Now antenatal is over. She has delivered. Come to the postpartum period. There is more chance of PPH. One very difficult situation we have crossed, and another difficult situation is a PPH. So oxytocin, the message is the oxytocin drip must be continued even after the delivery. Regarding methogen, I am not very sure. It can be given if blood pressure remains normal, because suddenly it may shoot up. This is also quite challenging. Proper systematic follow-up along with contraceptive advice in the postnatal period must be emphasized and also executed. खाली लिख नहीं देना है. Lactation has to be suppressed. Long-term follow-up. You can see some pictures, organs here. These are for the long-term follow-up, and pituitary gland, etc., and other organs are also to be looked after. To conclude, whether to manage a patient of accidental hemorrhage in a place where facilities are indeed adequate becomes a real challenge. The challenge is whether. So, the challenge is whether to refer the patient to higher center or management taking place, taking all the risk. It depends upon individuals' thinking and courage. If the higher center is far away, transfer could take long time, and obstetricians have to manage with available resources instead of wasting time. This is a very big challenge, of course. Taking all precautions, including legal aspect, one should remember. Taking risk bond is mandatory, we all take, but then hurry-burry situation is there, so one has to really be very sure about it. Bedside tests, as I have said, must be really encouraged, and everybody should know. Blood donation, of course, yesterday, the day before yesterday, we had Dr. Ratna Siri. He was telling about the auto transfusion of blood. I think this is an indication that we should also do it. Now, some practical suggestions that I would like to give is measurement of the abdominal girth at a fixed point is an easy method of assessing intra-abdominal hemorrhage. Though this is a rough estimation, it is useful to frequent assessment in the absence of USG. How do you know whether there is increasing blood inside the abdomen? Flow chart must be stuck up in our labor rooms and OT. APH drills must be practiced regularly as we do for eclampsia and PPH. These are some of the charts. And at the end, I would like to say, we doctors treat and God saves. Thank you very much.
Thank you, Pramila-di. It's very elaborate and covering all the aspects. So, the most important for us is vision of suspicion in all the patients with coming with pain abdomen in pregnancy, and earliest diagnosis matters. Thank you.
And now our next deliberation is by an stalwart in the field of obs and gynae. Madam Manju Geeta Mishra needs no introduction. She's teacher of teachers, and she will talk on placenta accreta spectrum challenges and diagnosis. And I'm sure this is a nightmare for every obstetrician. So over to you, madam.
Respected chairperson, dignitaries in the hall, I am going to tell you about past challenges in diagnosis and management. The clinical condition when part of the placenta or the entire placenta invades and is inseparable from the uterine wall. Pathogenesis, a secondary defect of the endometrial myometrial interface, a failure of normal decidualization in the area of the uterine scar, allowing an abnormally deep trophoblast infiltration of myometrial vasculature. The risk factors are consistent evidence from controlled studies, placenta previa, prior cesarean section, particularly with a placenta previa, in vitro fertilization. Inconsistent evidence from controlled studies, maternal age more than 35 years, prior dilatation and curettage of the uterus, prior myomectomy or other uterine surgery. Maternal smoking, anecdotal evidence from case series and reports, prior history of Akrita, uterine synecdoche or Asherman syndrome, prior endometrial ablation, prior uterine fibroid embolization, congenital uterine anomalies such as rudimentary horn and prior uterine irradiation. The incidence is gradually rising. In 1937, the incidence was only 1 in 30,000 deliveries, but now in 2010 it has increased to 3 in 1,000 deliveries. It is mainly due to rising rate of cesarean sections. It is also related to the technique of uterine closure and development of cesarean section scar defect. PAS increases with the number of cesarean deliveries. With one cesarean section, the incidence is only 0.42%, but after 3 cesarean section, incidence increases to 2.4%. Why is it dangerous? The average blood loss at delivery is 5,000 milliliter. 90% of PAS women require blood transfusion. The 40% require more than 10 units of packed red blood cells. Maternal mortality is as high as 7%. Maternal death may occur despite optimal planning, transfusion management, and surgical care. Complications: surgical, failure to separate from the uterus, massive hemorrhage, may need hysterectomy. Surgical injury to the ureters, bladder, bowel, or neurovascular structure. Medical can lead to DIC, acute respiratory distress syndrome, acute transfusion reaction, electrolyte imbalance, and acute renal failure. Akrita and maternal comorbidity also increases. It leads to increased incidence of ureteral injury, 2.1%, pulmonary embolism, again in 2.1%, may need ventilator in 14% of the cases, and ICU management in 26.6%. It is classified into histological classification and clinical grading. It is classified as accreta, increta, and percreta depending on the invasion of the placenta. A clinical grading system is done to assess and categorize placental adherence or invasion at delivery. No placental tissue seen invading through the surface of the uterus, partial, incomplete separation on with uterotonics and manual removal of placenta required, complete, no separation with uterotonics and gentle contraction with manual removal of placenta required, cesarean, laparotomy or vaginal delivery. Placental tissues seen to have invaded through the serosa of the uterus. A clear surgical plan can be identified between the bladder and the uterus. A clear surgical plane cannot be identified between the bladder and the uterus. Infiltrating the parametrium or any organ other than the urinary bladder. How to predict? Pre-pregnancy, first and early second trimester scan. Pre-pregnancy, first trimester scan, low uterine segment implantation, and cesarean scar pregnancy. Low uterine segment implantation, gestational sac typically implants in or near the cesarean section scar. The anterior myometrium appears thin. The placental, myometrial, and bladder uterine wall interface often appear irregular, multiple vascular lacunae within the placenta. Caesarean scar pregnancy, the gestational sac embedded in the caesarean section scar. It is surrounded on all sides by myometrium. It is separate from the endometrium. Color Doppler in a low velocity scale demonstrate surrounding vascularity of placental tissue. It is diagnosed mainly by imaging, the only method for prenatal identification of invasive placenta. The sensitivity and specificity are not 100%, which is to use MRI ultrasound. Ultrasound and MRI performed similarly for primary diagnosis in all studies. The MRI sensitivity is 92.5%, ultrasound sensitivity is 87.8%. It performed similarly for primary diagnosis in all studies. The advantage of ultrasound, it is relatively easily available, ease of performance, and main thing that cost is less. Ultrasound should be the primary screening tool for accreta in at-risk patients. Sonographic markers of placenta accreta, multiple vascular lacunae, loss of normal hypoic retroplacental zone, abnormality of the uterine serosa bladder interface, thinning of the retroplacental myometrial bulging of the lower uterine segment, increased placental vascularity on color Doppler, multiple vascular lacunae, loss of the normal hypoechoic retroplacental zone, thickening of the posterior bladder wall. The timing of delivery, the risk of urgent delivery must be balanced with the time of neonatal complications associated with the preterm delivery. SCOG recommends at 34 weeks and RCOG recommends 35 to 36 weeks with corticosteroid cover. But time must be individualized. The timing of the cesarean section should consider the desirability of performing it as an elective rather than an emergency procedure. If patient is stable, no APH, PPRM, or uterine contractions may be considered for planned delivery at 36 weeks. Recurrent APH, PPRM contractions planned preterm delivery around 34 weeks. It needs multidisciplinary team, maternal fetal medicine physician or obstetrician, pelvic surgeon, gynecologic oncology, obstetric anesthesiologist, urologist, trauma surgeon, imaging experts, interventional radiologist, and in the last, neonatologist must be present. Preoperative plan, ultrasound mapping of the placental attachment site to the plan, the skin and the uterine incision, plan individualized surgical management, the available choices if it is confirmed pass, a planned caesarean hysterectomy, leaving the placenta in situ, and other conservative management. Challenges during surgery. Multiple caesarean deliveries often present with pelvic adherence, thin and hypervascular lower uterine segment, bulky in situ placenta, deep pelvis, neovascularization, possible invasion to bladder, bowel, cervix, and parametrium in cases of placenta percreta. A planned caesarean en bloc hysterectomy is the standard management, especially if the woman is multiparous, older, grade 3, 4, or 5. Uterine artery embolization. It is used in two ways, for prophylactically or emergently. In bleeding that is difficult to be managed surgically, uterine artery embolization can be the sole endovascular treatment or combined with balloon occlusion catheter placement. This is, before surgery, you must place the ureteric stent to avoid injury. Use tranexamic acid before caesarean delivery. It significantly reduces intra and post-operative blood loss. Don't use uterotonics because it may cause partial placental separation. Incision on skin, midline vertical incision, it provides sufficient exposure if hysterectomy becomes necessary. Uterine incision, a classic incision often transfundal to avoid the placenta and allow delivery of the infant. Deliver the baby, avoid manual placental removal. The steps of hysterectomy: dissect the bladder flap, leave the placenta in situ, quickly use a whip stitch to close the hysterectomy incision, and to proceed with hysterectomy, total hysterectomy if it is possible. Trying to avoid urinary injury, avoid major intraoperative bleeding, limit visibility, create urgency for bladder dissection, avoid ureteric injury, placement of ureteric stents preoperatively, filling the bladder. It determines the appropriate site for separating the bladder. The bladder is filled with 300 milliliter of saline solution when to dissect urinary bladder. If there is no placenta percreta, it is done prior to delivery. It allows sufficient time to identify and create the vesico-uterine plane before an intraoperative bleed. If there is placenta percreta, delay the dissection. If bladder invasion is confirmed, instead of separating the bladder, it can be intentionally cut without touching the engorged vessels. Allowing a posterior approach may allow stepwise devascularization of the uterus. So posterior retrograde approach, open transversely 1 to 2 centimeter below the cervical vaginal junction from posterior fornix. Conservative management: patient should be preoperatively properly counseled and motivated. Agree to close follow-up monitoring in centers with adequate equipment and resources. The patient has a strong desire for future utility, hemodynamic stability, normal coagulation status. She is willing to accept the risk involved in this conservative approach. If leaving the placenta in situ, it is the standard conservative management. It may be the most appropriate choice in the most severe cases of MAP, in particular in cases of organ adjacent invasion, where radical surgery is often associated with severe maternal morbidity. Suggested benefits: a progressive decrease in blood circulation on within the uterus, parametrium, and the placenta. This will result in secondary necrosis of the villous tissue, and theoretically the placenta should progressively detach itself from the uterus and the percreta villi from the adjacent pelvic organs. After delivery of the fetus, no clinical evidence of percreta placenta, the surgeon may carefully attempt to remove the placenta by controlled contraction and the use of uterotonics. Failure to do so suggests the diagnosis of past disorder. No clinical evidence of percreta placenta. Placenta accreta syndrome: the cord should be cut close to the placental insertion, full repair of the uterus, post-operative antibiotic therapy administered prophylactically. Follow-up visits: first 2 months weekly, from 3rd month till complete resorption of the placenta, monthly visit. Structure of the follow-up consultation: clinical assessment, pelvic ultrasound, lab tests, serum beta HCG, infection screen on hemoglobin, leukocyte count, vaginal sample for bacterial analysis. Planned delayed hysterectomy is an alternative surgical management strategy for past disorder, especially if it is diagnosed intraoperatively. Time between 3 and 12 weeks postpartum. Advantage: estimated blood loss in this stage surgical approach, including both initial delivery and subsequent hysterectomy, has been reported to be less or similar to immediate surgery. Delaying the hysterectomy in complex cases may reduce other surgical morbidity. Disadvantages are: there is an associated risk of coagulopathy, hemorrhage, and sepsis during the period.
Sorry, but
uterus preserving surgery may be appropriate, and extent of the placenta accreta is limited in depth and surface area. The entire placental implantation area is accessible and visualized.
माफ कीजिएगा मैम, बट टाइम निकला जा रहा है. अगर आप
One
conclude
step
करें तो
conservative surgery
हाँ, और अगर
stepwise surgical
फटाफट हम लोग
approach,
रीड कर देंगे.
cervical tamponade 1 minute.
Yes, ma'am.
एक minute. Use of compression suture after placental separation, 3 main triple P procedure, compression sutures, Nausicaa procedures, which is the best conservative approach. The best studied conservative approach is leaving the placenta in situ. However, even this approach is of uncertain efficacy due to bias in case selection and uncertainty regarding the diagnosis of MAP. To conclude, ultrasonography screening is mandatory in pregnant ladies with identified risk factors for placenta accreta. Cesarean scar pregnancy should be actively managed as early as soon in pregnancy. The antenatal diagnosis and surgical avoidance of the placenta and its separation may be associated with reduced maternal morbidity, planned delivery in a well-equipped center with accreta team. The cesarean hysterectomy is the standard treatment management. However, leaving the placenta should be considered in difficult cases and when the woman is keen on conservation of her uterus or extremely difficult situation. Thank you very much for a patient hearing.
Thank you, madam, for such an informative and extensive, where you have touched each and every aspect of diagnosis as well as management, and very minute details of the surgical skills have also been dealt. Thank you, madam.
Now we have, amongst all the stalwarts, what more could we think of? Pramila Di, Manju Di, Shanti Di, amongst all of them, we have one stalwart in the make, that is Dr. Himanshu Rai, an able son of an able mother. He is doing an IVF clinic, I think since long now, and he'll tell us how to preserve more and more and get good healthy babies out of these IVF trials. Thank you.
Over to Dr. Himanshu.
Thank you, Mr. Nikhil, and I thank the organizers for giving me this pass जो होता है between two pass. I have been kept between two professors. उस हिसाब से तो I am totally non-academic. I have never been in a medical college as a teacher, but I had the luxury of getting classes from both these pass. Dr. Manju Gita Mishra and Dr. Shanti Roy, my mother. So, coming to the topic, I have been given this topic of optimizing perinatal outcome in ART pregnancy. So, people will think that why in a labor conference we are talking about this ART pregnancy, so gusane kya zarurat tha? So, the reason is simple. Because we know that now when we had started IVF and when people were getting IVF from outside, from Bombay and Delhi, they used to go to Madras, Calcutta, everywhere. And after 2 or 3 months, at many places, they used to stay at our cities, the metro cities, for the deliveries. But sometimes they used to come back, especially when they were working class or something like that. So they usually came to me because I was doing IVF, so they said that only you can understand, and I was like flagbusted that any person can do, any gynecologist should be knowing that how to handle these pregnancies. But as more and more IVF clinics are now opening up, more number of ART procedures are being done in not only in Patna but in so many cities of Bihar now and East Zone, in many places it is being done, and these patients, it's difficult for them to go to the IVF clinic for perinatal, like for their antenatal examinations, and doctors, when they get these patients who have not done IVF, then they get confused that what to do with this IVF pregnancy, how it is different from a normal pregnancy, what to do. So all gynecologists, even if they are not doing IUI or IVF, will get these antenatal patients either just for a routine checkup, or they might come to them in an emergency, like they are having a bleeding at 2 months, 3 months. They cannot go back to the center where IVF was done. So they will go to these doctors who are the normal gynecologists not doing IVF. They don't know that what drugs are being given, why they are being given, and it can become confusing for them. So that's why the relevance of this topic. And they should also know the complications of IVF. What can happen in IVF pregnancy and how to handle those things, at least initially, before you can refer the patient back to the IVF centers. Another problem is that many places where IVF is being done, including ours, we don't want to spend too much of our time on the antenatal part, because almost 80-90% can be handled by any obstetrician or gynecologist. We want to focus more on the doing IVF, but we have to do the antenatal of those patients also, and these patients are pampered so much, they have been with us with so much time, and when they go to some other clinic and treated as a normal patient who has spontaneously conceived, then they don't feel satisfied and they think that no, यहाँ पे अच्छे से मेरा इलाज नहीं हो पाएगा, and they come back to us. We don't want patients from faraway places coming to us for no reason, just because only their IVF was done at our place. So this is why it is important to know about these things. Yes? So we think that IVF pregnancies are precious pregnancies. And people say that why IVF? Every pregnancy is a precious pregnancy. So all the pregnancies are precious. So what is special about this IVF pregnancy? But you should not forget that for IVF, though it can be for some people that it might be easy to get IVF done, but most of the patients who come to us from middle income group and low socioeconomic group, they sometimes have spent all the earnings. They have taken loan to get that pregnancy. So if you're talking about precious, then definitely this is a precious pregnancy. So for them it is very precious. Life does matter, for life is important equally for all, but these have to be treated specially. So what are the possible causes of adverse outcomes in ART pregnancy? First thing is multiple pregnancy. So almost 20-30% of the pregnancies can be multiple pregnancies. The age factor, usually the patients when they decide for going to IVF, then the age is already 35, almost sometimes 40, and many patients have come for egg donation, embryo donation. So they can be even 45, 50 now with the ART Act. Women more than 50 years are not allowed to get IVF done, but even between 40 and 50 years, it's not a natural age for pregnancy. The nature shuts down the mechanism of reproduction by 40 years. So we have to deal with the age factor also. Then the congenital anomalies can be higher due to the process, due to epigenetic modifications, and due to ICSI also. Some people think that there might be some damage or future damage. Then the early pregnancy loss, ectopic pregnancy, and other obstetric complications. So we know that with the age there is congenital malformation even in spontaneous conception, and in ART, since they are more of the higher age group, so we'll be getting more of these patients with more pregnancy complications related to the age, and so it increases the maternal morbidity and mortality. So you have to be very careful about these women. Early pregnancy loss, the incidence is, in this study it has been shown to be 12.5%, but other than this, early pregnancy loss is more common in IVF because you diagnose it very early. Even if there is 1 day overdue, the patient gets their blood test done, and it is when beta HCG positive, it is a chemical pregnancy, so which are not usually done in a normal pregnancy, spontaneous pregnancy. So we will be diagnosing more pregnancies at very early stage, and that's why there can be increased pregnancy incidence of early pregnancy loss in IVF. And definitely the risk of extrauterine pregnancy has been found to be almost 2.5-fold compared with natural conception. Risk factor can be history of tubal ectopic and tubal surgery. We know tuberculosis is so common. So if they are going for IVF, we must see, and if clipping is needed, then we must do the clipping or salpingectomy in these cases to prevent ectopic. And higher number of embryos also are transferred, so increases the risk of ectopic pregnancy. So multifetal gestation, again, the recent data from ASRM, American Society of Reproductive Medicine, has come, which has shown that the singleton birth has increased to 93% in 2020 from 93% in 2019. The reason is that now more and more centers are going for single embryo transfers rather than going for 2 embryos or 3 embryos or 4 embryos. So even the ART bill of India also has come out with not more than 2 embryos to be transferred normally, and in exceptional cases 3 embryos can be transferred, like advanced maternal age, history of recurrent implantation failure, and these cases. So the incidence of twinning and triplet pregnancies and multi-order pregnancies is decreasing with these legislations, and twin birth has decreased from 6% to 7%, but still quite common, and triplet birth has remained at 1%. So risk of monozygotic twin also is increased almost 2.25 times, and there are various obstetric complications, not only for the women of lower age group but higher age group also. The incidence of first trimester bleeding, PIH is very common. Many women of these will be having chronic hypertension, so these have to be screened before going for IVF and properly taken care of. The gestational diabetes is also very, very common. Placenta previa, abruptio placenta, preterm labor, IUGR, intrauterine fetal death and cesarean section incidence. These are all increased in cases of ART. There are various congenital malformations due to, again, increased maternal age, ICSI, embryo is exposed to mechanical, thermal, and chemical alterations, and increase of imprinting disorders, cryopreservation also. So these are some theoretical reasons for increase in the congenital malformations, but not 100% proven. So guidance on the limit of embryo transfer, as I told you, different societies have got their own guidelines. We have to follow the ART Act now because it's not a guideline, it is an act. So not more than 2 embryos to prevent the chances of twinning. Confirmation of pregnancy has to be done. So after IVF, many patients go back to their hometown. So you have to see by beta HCG that whether the pregnancy is there or not. If it is not there, then you have to stop the drugs that are being given. Then transvaginal ultrasound to be done to rule out ectopic pregnancy, confirm the viability, and also the number of multiple pregnancies and heterotopic pregnancy should also be considered. So the main thing that what we should know, or the gynecologist should know, that what hormone replacement has to be given during pregnancy, and it will depend upon whether the transfer has been done in fresh cycle or frozen embryos have been given, whether it has been done in a premenopausal woman or a postmenopausal woman, because in a postmenopausal woman, in cases of especially egg donation or embryo donation, the replacement with estrogen and progesterone is mandatory. The body cannot produce its own estrogen and progesterone, so it has to be given from outside. But in cases when the premenopausal and even with the self eggs also, it can only progesterone is needed. So you have to know that whether the ovaries of that woman are functioning or not, whether suppression was given or not, whether the cycle has been done in a stimulated cycle or hormonally replaced cycle. So accordingly you have to judge that whether estrogen is needed, progesterone is needed, or both are needed, and whether progesterone has to be given in low dose or high dose. So it will depend upon what procedure has been done. For how long luteal support is given until placenta has formed, and it is 10 to 12 weeks, though some studies have shown that it is not needed till 3rd month of pregnancy. Some people may stop, but I have not seen any doctor in India stopping the progesterone before 10 or 12 weeks. So you have to give this extra support after 12 weeks. The pregnancy of IVF pregnancy is just like any other normal pregnancy. So you must remember that if a patient comes to you at 5 months, then you should not be confused that there might be some other drugs that have to be given. You have to treat that patient as any other pregnancy. The use of many of these women will also be on aspirin, low molecular weight heparin, because at many centers it is a routine to give these things. At many centers it is given in indicated patients. So, but just to increase the flow of the uterus, the sildenafil is given, prednisolone might be given for some cases, IVIG, GCSF to increase the endometrium, but this is not continued after the pregnancy has established. The intralipid, IVIG, so there are many drugs which have been given to increase the pregnancy. There is no evidence which supports their use, but it is used in cases because the patient and doctor both get desperate that how to get the pregnancy. Another problem is of fetal reduction. Sometimes patient will come to you with four sacs inside the uterus. So you have to ask them to go for fetal reduction. It is quite safe and established procedure. We have been doing it since long, and we have also presented papers on fetal reduction. So we can reduce from 3 to 2 or from 3 to 1, whatever the patient's demand is there, and it should be done around 10 weeks of pregnancy. It should not be delayed very much. Then anomaly screening, just like any other pregnancy, chances of anomalies are increased in ART. So anomaly screening is very, very important. Double marker test is routine at our places, and when indicated, NIPT also we do. Even if double marker is negative, it tells you only about 2 like Down syndrome screening. There are so many other chromosomes also. So if there is any such history, then we can do NIPT also. And if something comes out of NIPT, then we can, or on ultrasound, if there is anomaly, then we can send the patient for amniocentesis. The time and mode of delivery, people think that IVF means cesarean section. Patient also want to be safe, but there has been no study which has shown that IVF is a better option for it. Should be treated judiciously, rationally, and if indicated, then cesarean should be done. Otherwise, they can easily go for normal pregnancy also. So the take-home message is that single embryo transfer should be encouraged. Luteal phase support is very important in the first trimester. Regular antenatal checkups and monitoring, first trimester screening, antenatal steroids when indicated. Judiciously decide time and mode of delivery, and proper neonatal care should be done. And take clinic message is that important to know about what exactly the procedure has been done, what replacement is needed, what is the location of pregnancy, early diagnosis and proper management of late onset ovarian hyperstimulation syndrome also, medical management of coexisting and new onset disease during pregnancy, closer supervision and pampering of the patient. They need a lot of love because when they come to us, they are very special patients who have conceived with IVF. They are our advertisements. So we pamper them a lot, but when they go to some other clinic, they are just treated like any routine pregnancy. So kindly do pamper them. Thank you so much.
Thank you, Himanshu. Your talk was very good, very clinical oriented, even for people us doing general practice. It was very good. How much progesterone, how much estrogen, until when, and to whom. It was very informative. Thank you so much.
Now, I am really proud to invite another legend, Dr. Madam Padma Shri, Dr. Shanti Roy. Though she needs no introduction, she is the teacher of the teachers and a very great gynecologist, a very loving personality, known for her hard work and her attitude towards the patients. I call Dr. Shanti Roy Madam. She will tell about preserving uterus in past. Is it?
Thank you very much. Respected chairpersons, learned delegates, our invited guests. My subject is conservative management of placenta accreta spectrum. The term spectrum is used because the placental, what is placenta accreta first? It is abnormal invasion of the trophoblasts into the myometrium. In normal pregnancy, the trophoblastic invasion remains away from the placenta. It is in the decidua, but when it crosses the decidua, enters the myometrium, it is called accreta. It can be of minor degree, it can be of major degree, and that's why it is called in accreta, increta or percreta. Percreta means the villi invade up to or beyond the uterine serosa. Now, there are various risk factors, as you have already seen in the slides of Dr. Manjugita Mishra. She has already described that previous cesarean section is the strongest factor in placenta accreta risk. And placenta previa is present in about 80% of the cases. There is increasing number of accreta cases now than it was before. And as the incidence of cesarean is increasing, the incidence of placenta accreta is also increasing. Diagnosis, you have already learned that it is mainly by ultrasound, in cases sometimes aided by color Doppler, and in some cases when there is diagnosis in doubt, then MRI's help can be taken. Advanced maternal age, smoking, uterine anomalies, previous uterine surgery of any type like myomectomy, Asherman syndrome and use of ART are other risk factors besides cesarean section and the placenta previa. The conservative management means to save the uterus for future fertility. Now, before I proceed for the conservative management, I must mention that the best treatment for placenta accreta is hysterectomy with placenta in situ after delivering the baby by cesarean. Because in placenta accreta, whenever conservative management is given, there are chances of complications, there are complications to the mother, and therefore it is best avoided until and unless the mother or the family is very keen to give conservative management and to save the fertility. It is effective in 75 to 80% of the cases according to literature. There are various methods of giving conservative management. They are expectant, extirpative, one-step conservative surgery, and triple P procedure. The expectant method first. In this method, the baby is delivered by cesarean. As Dr. Manju has already told you, that the incision is usually, skin is incised vertically in lower abdomen, and the uterine incision is given away from the placenta previa, and that's why before surgery, if the diagnosis has been made, the upper border of the placenta previa is mapped out, and then incision is given above the upper placental margin. Then after delivering the baby, the placenta is left in situ. No attempt is made to separate the placenta or to take out the placenta, and then the uterus is closed, abdomen is closed, and then this is the expectant method. The complications are PPH, infection, sepsis due to remaining placenta, sometimes delayed hysterectomy is required, uterine AV fistula can occur, and in some cases choriocarcinoma has also been reported. The second method is called extirpative method. What is extirpative method? This is usually done by or provided by most of the obstetricians. They try to separate the placenta and take out the entire placenta by force. This is forceful attempt of manual removal to not leave any part of the placenta. This procedure has got serious risk of postpartum hemorrhage and sepsis. If the entire placenta gets removed, then postpartum infection and sepsis is decreased, no doubt, if the entire placenta can be removed. But this is very dangerous, and it is associated with severe bleeding during the operation. Then the third is one-step conservative surgery. It is also called resective conservative surgery. It is resecting the placenta with myometrium in block. First, the newly formed blood vessels between the uterus and the surrounding structures are ligated. Then uterus is opened, baby is removed, and the placenta is removed with the affected area of myometrium until healthy tissue in the myometrium is reached. That means placenta as well as myometrium are removed, and then uterus is reconstructed in 2 layers after securing hemostasis. The success of this procedure depends upon the type of placental invasion. That means if only small part of placenta has invaded the myometrium, then it will be more successful. Otherwise, if the entire placenta is invaded, it is not possible. Then the last is triple P procedure, and in this procedure, the help of interventional radiologist is required. The perioperative location of the upper border of placenta is first done, then then the baby is delivered, and pelvic devascularization is done, because before delivering the baby, before opening the abdomen, there is a pre-placed pelvic arterial balloon catheter in the anterior division of internal iliac artery, which is done by the interventional radiologist. And then the baby is delivered, and then it is embolized through the balloon catheter, and in-block resection of the placenta and myometrial tissue is done, and then myometrium is reconstructed in 2 layers or 3 layers depending upon the need. So the entire placenta with the myometrium is removed, and this is called triple P procedure. The myometrial resection may not be possible when the cervix is involved or when the placental extension is towards the lateral in the parametrium or in the reaching in the bladder. Now the adjuvant, after you have done conservative treatment and you have left part or entire placenta, then the adjuvant treatment is in practice to prevent secondary postpartum hemorrhage and infection, and to accelerate the placental resolution after conservative surgery. The placental resolution takes place in 95 to 120 days. The methods of adjuvant treatment are methotrexate injection, uterine devascularization, and hysteroscopic removal of the retained placental tissue. Now, methotrexate is generally practiced by most of the obstetricians because it reduces the vascularity of placenta, causing its necrosis and accelerates its resolution. Thereby, it diminishes or minimizes the risk of infection and PPH. But the various professional bodies like RCOG, ACOG, FIGO, they do not recommend its use in placenta accreta syndrome. It should not be used. Why? Because it is not very effective in these cases. It is effective in early pregnancy, but not in late pregnancy. And therefore, the placenta is not very respondent to the methotrexate injection. The nephrotoxicity can occur, pancytopenia can occur, which leads to increased risk of secondary infection, and it is also contraindicated with breastfeeding. Therefore, methotrexate should not be used for placental resolution. Then the next method is uterine devascularization. Various methods are adopted for it. They are iliac artery embolization, bilateral uterine or hypogastric iliac ligation, or balloon occlusion. The complications of embolization are endometritis, uterine synechia, uterine perforation, internal iliac artery perforation, and premature ovarian failure. The next method is hysteroscopic or laparoscopic or ultrasound guided resection of the retained tissues which have been left behind. Now, this is done after some times so that placenta gets time to get necrosed, the blood supply to the uterus diminishes, the placenta gets necrosed, and then it becomes easy. This is to shorten the period of placental elimination after conservative management in past, and thus minimizing the risk of sepsis and PPH. It should be done only when placenta shows no sign of vascularity on Doppler examination. The risks are uterine perforation, bleeding, and delayed endometriosis. The follow-up after conservative treatment, we have already heard, it is done every 2 to 4 weeks. Clinically, we inquire for vaginal bleeding, foul smelling, discharge, uterine tenderness, or fever. Ultrasound is done to see whether any remnant is present or not. If fluid or blood products or avascular echogenic material is found, it is normal. Thick endometrial echo and endometrial mass are indicative of RPOC. CD shows hypervascularity with above findings if the placental tissue is retained. Serum beta HCG level, it drops to less than 5 over 21 to 35 days. CBC should be done at each visit. Placental resorption occurs in 95 to 120 days. The risks of conservative management are many. You have already heard risk of recurrent PAS in future pregnancies if the patient gets pregnant, risk of PPH in future deliveries, increased risk of uterine rupture, uterine synechia, and Usherman syndrome. These risks are associated if you leave behind the uterus. Need of extensive counseling of the patient who wish to preserve fertility with an extensive accreta. Adequate expertise of the surgeon is mandatory. Availability of interdisciplinary help and adequate blood bank facilities are essential. Data is limited for conservative management, and that is not the management of choice for placenta accreta. The best management when diagnosed antenatally is delivery between 34 to 35 or 36 weeks of gestation, by cesarean hysterectomy. If the facilities are not available, the patient should be transferred to a level 3 or 4 center where facilities of blood bank and interprofessional team are available. Hemoglobin level should be optimized before delivery, coordination with the blood bank to ensure supplies, and close monitoring after delivery of hemodynamic status and blood loss should be done. Now, thank you very much for your patient hearing.
Madam. You have given a very elaborate and very nice description of how to preserve the uterus, what to do in the post-operative period, and during the operative also, what surgical methods should be followed. Ma'am, you have enlightened our knowledge a lot, and it's a really surgical emergency.
Dr. Himanshu, could you?
And
the good part is, can I request the chairpersons to also join us forward, because we are already delayed, and I request the photographer. Can I also request Dr. Vinita Singh, Dr. Alka Pandey ma'am to join us for a photograph? Yes, ma'am. Dr. Shanti, aaiye na. Can I request Dr. Pragya ma'am also?
Madam Shanti Roy, I had one question, madam, before they... have you ever had to leave placenta in situ and how it ended?
वो तब तक फोटो ले लेंगे, उसके बाद जवाब दे देंगे. डॉक्टर शांति रॉय को तो दे दो, आ गई हैं तो मैं फिर माइक दे देता हूँ. डॉक्टर शांति रॉय का, डॉक्टर शांति रॉय का. Dr. Shanti, could you just accept this, and then definitely I'll give you the chance to answer. Yes, this is for Dr. Himanshu. Can I request Dr. Madhuri Patel ma'am and Dr. Sampath Kumari ma'am to also join for a quick photograph? कोशिश तो वही है. Can I request the chairpersons for the next session to also please join us? तो अभी सीढ़ियाँ खाली है तो ट्रैफिक जैम कम रहा. Yes, Dr. Pragya Mishra is presenting into Dr. Himanshu Roy. सब लोग ध्यान से देखिएगा. This is a chance that you're never going to see in a trillion years. The stars have aligned together. And now I request Dr. Vinita Singh also giving it to Manju, Dr. Manju Geeta Mishra ma'am. And she's very happy. Both of them I meant to say. ये मौका मिला, उन्होंने हाथ पकड़ा. Thank you so much. All right. Can I request the chairpersons? Everybody look into the camera. And can I request the chairpersons for the next session? I would also like to let everybody know this session is sponsored by Reuben Hospital. Thank you so much for your support. Can I request the chairperson, Dr. Vinita Singh and Dr. Suchita Chaudhary, to please, and Dr. Shipra Roy, to join us as the chairperson. Our speaker is Dr. Sethu Varun Kumar. Can I also request our speaker to join us on the dais, check the presentation. Thank you. कोई आया नहीं आया? Can I also request for the panel discussion together, we've got the experts, Dr. Vijay Kumar, Dr. Mona Lisa Singh, Dr. Neha Singh to also join us on the stage. Dr. Mona Lisa Singh and Dr. Neha Singh, please. The time has... All right, can I request all to please settle down? Dr. Sampath Kumari, Dr. Abharani Sinha, thank you. I would request Dr. Sethu to please get started.
Very good morning to the respected seniors, dear colleagues and the juniors. Thank you, Team Foxy. Am I audible? Am I audible? Hello? No, it's all about the people sitting at the back.
The backbenchers.
Okay. Thank you, Team Foxy, for giving us an opportunity to discuss about critical care in obstetric practice. I am Dr. Setu Varun Kumar, and we have Dr. Vijay Kumar, Dr. Mona Lisa, and Dr. Neha with us. When I walked in, I got this ID, and then on this ID it was written, "Safe motherhood is her right." I think the best logo statement that could anyone have. साथ में और भी लिखा है, स्वस्थ नारी सुखी नारी. स्वस्थ नारी सुखी नारी सिर्फ नहीं है, वो पूरी फैमिली को भी सुखी बना देती हैं. So this should be the motto, and it has been very beautifully depicted by Team Foxy, and I congratulate them for this. लेकिन how do we measure? There should be some indices कि स्वस्थ जो हैं वो कितने स्वस्थ हैं. How are our services? How are we going to rate them? MMR is one of the indices by which we can rate that. When we compare the number with some of the countries like US and UK, they are having the numbers of 10 or 15 or 17. Some countries are having even less than that. But in our country, the number is nearly, the most recent data is nearly 97. The number seems very disappointing. But I think there's been a huge work done by the obstetricians and the multidisciplinary approach, which has led to the decline in the MMR since 2014. In 2014, as we can see, it's around 130, and now in around 2018 to 20, it's 97. Why there's a gap between those countries and our country? Why there's a gap between a Kerala who is having an MMR of around 46 and Assam who is having an MMR of more than 200? I think we can summarize the gaps between 4 topics: knowledge gap, communication gap, poor resuscitation skills, and availability of the facilities. And I think most important thing is organization of these kind of seminars will be the main thing which will cover these kinds of gap. The knowledge gap, communication gap, poor resuscitation skills, and availability of facilities. I'll be repeating them time and again because we need to understand what facilities we are having at our institution, in our wards, and when we need to refer. I was very happy to listen to most of the speakers who were saying that, okay, we are taking the help of an obstetric, anesthetist, cardiologist, nephrologist. Yes, that is the demand of the day. We need to refer. We need to refer them as early as possible. We need to take their opinion. So most important thing is recognition. When should the mother be transferred to ICU? I'll ask Dr. Neha to give her take on it. Please, Dr. Neha.
Good morning, everyone. So yes, Dr. Setu, you asked a very relevant question, and I think yes, there is a scope. I mean, there is a place of correct referral of obstetric cases to a higher center, which is supported by ICU, HDU, and an obstetrician on floor, along with anesthesia team and cardiac interventionist. So those scenarios are pregnancy, with most of the referrals which higher center receive are in cases of postpartum hemorrhage. Then making to second of the list is pregnancy with hypertensive disorders, severe preeclampsia, eclampsia. Then we have placental adherent cases, accreta, percreta. Also pregnancy with cardiac diseases, pregnancy with jaundice. They are the cases which should be referred to higher center, where a multidisciplinary approach can be provided to the motherhood for a safe motherhood. Now, if in general I talk about the warning signs, that when we should be alert to refer a case, those includes, of course, for hypertensive disorders, are headache, persistent hypertension, then epigastric pain, blurring of visions, excessive profuse bleeding after childbirth, or loss of consciousness in a pregnant lady or after giving birth to a child, or in case of sepsis, hypo or hypothermia. So these are the cases where we should be alert and refer those cases to higher centers. There, for us as an obstetrician, because we are supported by multidisciplinary approach, an ICU, HDU, and an anesthesia and a critical care team, decision making is easy, and it's for a safe motherhood, it is required. So thank you, Dr. Setu.
Thank you, Dr. Neha. Multidisciplinary approach gives us helps us in decision making. That is the most important thing. If you are able to decide that yes, this is what the patient requires, whatever be it, then we will be able to treat the patient better. Initially we can go for shock index, modified shock index, rule of 30, or we can use Muse scoring, in which there will be a normal number, and then if the number increases or decreases, then we will be grading the patient into 1, 2 or 3, as we can see there. And we'll grade the number, and we'll have the format in wards, so that we can analyze them. If the patient is having a 0 number, routine care, 1 to 3, it's a low grade response, refer to a secondary health care, 4 to 5, refer to a tertiary center. If the number is greater than 6, send the patient to HDU or ICU. This appears to be a bit complicated, but it's not. The parameters are systolic blood pressure, diastolic blood pressure, respiratory rate, heart rate, percentage of oxygen. We actually do monitor them, but we are not just trying to make a grading of them so that we could refer the patient early. Similarly, this another one, maternal early warning scores. Here also there will be yellow alert and red alert, and the patient is persistently in the yellow or red alert, then you need to refer the patient. So that was the first part, what we intended to talk. And now we will talk about the most common complications with which the obstetric patients come to us: hemorrhage, hypertensive disorder, sepsis, amniotic fluid embolism, or cardiac disease. Massive hemorrhage can be because of placenta previa. There have been many speakers on this, so I'll not go much into the detail. What are the goals here? Goal is controlling the source of blood loss, where the obstetrician and sometimes the interventional radiologist plays a very important part. And then there is restoring adequate oxygen carrying capacity and maintaining adequate tissue perfusion. Tissue perfusion is one of the most important things which we generally do not notice. That is the most important thing. Because of less tissue perfusion, the patient will land up in AKI or will have the problems related to liver and coagulopathy as well. We need to be good at history taking, vitals, estimation of blood loss, classification of hemorrhage, lab evaluation. All those things are routine. In the lab evaluation, coagulation profile is one of the most important things which we need to have. Assessment of platelets, PT, INR, fibrinogen level, and sometimes even TEG. TEG is thromboelastography. We need to have 2 large bore IV access. Central line is not a must at that time. Teamwork is the most important thing. Then there is fluid therapy and blood product transfusion. We know that the colloids should be the first choice for resuscitation, and we can give it in the multiples of 3 times that of the blood loss. Crystalloids are the first choice. Then we can give colloids, which is in the range of around 20 ml per kg. That means we can give up to 2 bags. Then blood transfusion, FAP, cryoprecipitate, PCC, and platelets. Prothrombin complex concentrate is a new thing which has come up, and it comes in a powder form in a vial, and it contains around 1000 units, and we need to add 40 ml of normal saline to it. We can give it in the patient who are having coagulation disorders, and depending upon what is the INR, if it is in the range of up to 4 or up to 6 or more than 6, we can give in different values. Just imagine we are giving only 40 to 60 ml for correcting that INR, rather than FFP, which is a blood product having all the complications of a blood, which is having so much of volume. We need to have that ABO and RH compatibility, which is not required with prothrombin complex concentrate. And along with that, there is also one thing, that the INR correction is far better with this. So we can go ahead with this. This is available in Indian markets. The price is high, just as factor 7, but still it can be used. For 1000 units, the price is around 40,000. Then we should initiate, if required, massive transfusion protocol. Then there are utotonic drugs, and the basic things like inspection of vagina, cervix, performing of laparotomy, like getting bleeding vessels and all. Now the most important thing is hemodynamic monitoring. Simple thing is urine output. Urine output is considered to be the poor man's cardiac monitor. If it is in the range of 0.5 to 1 ml per kg, then we are happy. If it is less than that, we need to be worried. Why this is happening? Why the urine output is less? We should be focusing on that. It might be because the patient had a significant period of hypertension, and by that time the AKI has started to set in. The second thing could be that the patient, the fluid volume itself is so less that the urine output is not coming. So simply we need to give fluid. We need to understand that. Then there is straight leg rising test. Straight leg rising test is a very simple test. We can perform, if the patient is lying on the bed, we can just elevate the legs side by around 30 to 45 degrees. We can wait for a few minutes. Even if you are not having any invasive monitor, you can see that if the systolic pressure tends to increase by 10 to 15, that means the patient is fluid responsive. Fluid responsiveness is one of the most important things which we need to focus when we are resuscitating a patient. If we are doing that and the BP increases, then we know that there will be benefit of giving fluid. Or if there is no increase in blood pressure, we need to understand very well that fluids are not to be given. We need to balance the fluid and the diuretic so that we could maintain the lung condition. Now the most important thing is invasive arterial blood pressure monitoring. Generally we prefer the left radial artery for that. It's a simple, it can be a simple IV cannula which we would insert, and then there is a transducer and that is connected to a monitor. And that monitor will show you some graphs. You can see that graph in the bottom right side. There are some waves going up and down. There are plenty of waves going up and down. Can I have a pointer? Okay, see, those are the waves which are going up and down. When we are inserting an arterial line, we are having the BP which is generated by each and every beat of the heart. That you need to understand. When we are using an NIBP, it gives us a reading in around 2 to 3 minutes. And moreover, when the patient is in hemodynamic compromised state, that reading will not be reliable. So this is the arterial line, and it's this trace is the most important thing. The tracing will be the similar. You can see when you have applied the pulse oximeter and you can see the waves of the pulse ox. Similarly, there are arterial waves. And based on these arterial waves, you can very easily analyze and say that yes, the patient is deficient on the fluid side and we should be giving them fluids, or the patient does not require fluid at present and we should go more towards the vasopressors. See, at one point it's a bit high, other point it's a bit low. That is called pulse pressure variation. If the pulse pressure variation is greater than 13, then we will be giving fluid to the patient. There are a few other ways in which we can analyze. One is IVC ultrasound. What is IVC? Inferior vena cava ultrasound. It's a very simple thing. Now all of us are using ultrasound, especially in ICU. It's a hand-on thing which we have to use for all the patients. We can just use it in the subxiphoid space and we can see the inferior vena cava. That is the inferior vena cava we are seeing. See? Now, if its diameter is more than 1.5 centimeter and if it is not moving with the respiration, that means the patient is full. That means the fluid is enough. You are not supposed to give fluid now. If you are going to give fluid, then the patient will go on, it will be heart failure, then the patient will have Krebs. One of the most important thing is having all these monitors, the basics should not be forgotten, that always auscultate the base of the chest, always, because those are the first things which will give you an idea that yes, the fluid is more than enough, you need to stop, now you need to go to, for inotropes if it is still required, or you need, if still you need that the oxygen carrying capacity is less and you need to give blood, then first you need to give diuresis and then and only then you will give the fluid. I spoke about passive leg rising test, and at that time I was saying passive leg rising test when radial line was not there. Now when the radial line is there, then there is 9% increase in stroke volume or 10% increase in pulse pressure. These might sound very weird or new things to you, but they are very simple things and they will be just demonstrated on the monitor. That those numbers will come on the monitor. You have to see the numbers and then you have to give the fluid or the vasopressors, whatever is the requirement according to them. Very sorry. Pulse pressure and stroke volume variation we talked about, IVC ultrasound, and then there is transthoracic echocardiography, CVP line. Okay, if the patient is requiring multiple inotropes which cannot be given by the periphery, then you need to put a CVP line, but CVP line is never to be put in an emergency. It is time-taking procedure and you need really good expertise for putting it in an emergency. Even pulmonary capillary wedge pressure is things of past and we are not using them. We'll talk about hypertensive disorders, preeclampsia, eclampsia, HELP. Everyone knows the gist of those diseases. The important thing is two. First one is reduction in colloid oncotic pressure and increased capillary permeability. That is, the pregnant ladies are always prone to pulmonary edema. The moment you are giving enough fluid, they will go into pulmonary edema. But in case of hypertensive disorders, there is another confusion, that there is increased systemic vascular resistance and reduced intravascular volume. So these kinds of patients, especially in these kinds of patients, the hemodynamic monitoring becomes a very important thing, because slight more fluid, pulmonary edema, if you are not giving fluid, then If you're not giving fluid, then? Yeah, so you need to understand, yes, the patient might go into renal failure. What is the aim of the management? Two important aspects: termination of pregnancy and control of hypertensive emergency. What is the aim? You need to understand that most of the patients who are coming to you, they are having a BP of around 210, 20, and the diastolic part is around 120 or 130. So what will you do? What is your aim? Normal BP? No, never. See, you need to understand that their vessels are prone to be dilated because of that extreme pressure. Now if you are reducing that pressure suddenly, the vessels will collapse and the perfusion to the organ will not be there. So they will suddenly go into kidney failure or hepatic failure. So those things will be very fast. So the target should be to decrease the MAP by 20 to 25% within the first 2 hours. Then bring down the blood pressure to 160, 100 within first 6 hours. Then target BP should be 150, 100. We should not be over enthusiastic and aiming for 120, 80. No, please. Those are not the golden numbers for these kinds of patients. Then control of seizure is most important. MgSO4 is being given at the rate of 4 to 6 gram IV over 15 minutes, followed by infusion 1 to 2 gram. If there is a recurrence of seizures, we can give more boluses. Most important thing is range. When we are giving MgSO4, kindly repeat magnesium levels at least 6 to 8 hourly. It has to be in the range of 4 to 7 milliequivalent per liter. We have to be very much alert about our labs on what values they are giving. 4 to 7 is milliequivalent per liter. Those numbers are different from the values which would come in millimoles per liter or milligrams per liter. So those things are different. You need to be very vigilant when you are seeing them, because if there is excess of magnesium, then the patient might have initial signs would be decreased in reflexes, respiratory rate might decrease, and if the level goes beyond 12, then even a cardiac arrest might be there. Calcium gluconate is the specific antidote. Then we'll talk about HELP syndrome. The name itself suggests that hemolysis will be there, SGOT, SGPT will be raised, platelet counts will be decreased. Now we are worried about complications. DIC, pulmonary edema, acute renal failure, hepatic rupture, infarction, ARDS, and placental abruption can occur. Now there is a very simple slide, but I think each and every point of that slide is gold. Each and every point of the slide is gold. I'll just go through it. There it is, start neuroprophylaxis with MgSO4, 4 gram IV load over 20 minutes. If the patient is already in renal failure, then rather than going for MgSO4, you can give phenytoin. You need to understand that magnesium is being excreted by kidney. If the kidney function is not good, then the patient might very soon go into the toxicity phase. Definitive treatment is delivery, and for fetus, if there is non-reassuring fetal status or placental abruption, emergency cesarean delivery after maternal stabilization should be done. Watch for hemorrhage and DIC. For neurologic, is there any seizures? You have to repeat MgSO4, and if it is not subsiding, then you have to give phenobarbital also. You also have to think that despite all your measures, if you are not able to control, then there might be something going on in your brain. You might have to go for CT or MRI. Now we have to look at the renal factors. If there is decreased urine output, patient is going into acute renal failure, then we need to think whether the patient is having pulmonary edema or not. Just auscultate the basis and you will come to know. If the patient is not having pulmonary edema, give fluid boluses, and if the pulmonary edema is present, then you give diuretics. Lasix can be given. For BP control, hydralazine or Lobet can be used. Initial they have to be given in the bolus, and then they can be given as infusion. Now there's an entity called PRESS, posterior reversible encephalopathy syndrome, which is a clinical radiological diagnosis. The patient will present you with the basic symptoms of eclampsia like headache, confusion, visual disturbances, seizures, and when on CT or MRI you can see transient changes of edema on neuroimaging. Why this is important? Again, because in more than 90% of the eclamptic patients are having these problems. Because of the wide availability of CT and MRI, we are able to diagnose them. Basic treatment will remain the same. Antihypertensive, magnesium sulfate, and even propofol, benzodiazepines or phenytoin can be used for control of the seizures. Complications can be ischemia, hemorrhage, herniation. Permanent neurological disorders can be there, like seizures, epilepsy. Death can also be reported in 15% cases. Now we'll talk something about the respiratory system. This is a basic ABG. You need to look at these two numbers. First one is the non-pregnant, and you can see the last one, term. PCO2 is around 40 in a non-pregnant lady, person, anyone. But in a term lady, it has to be 30. This number is very important. Please do not confuse. When you are seeing an ABG, don't see that the number is 35 or 40. Okay, this is normal. No, it is not. It is catastrophic number. 35 means there is impending respiratory failure. The patient might collapse soon. If it is happening, and if there is 40, then you need to understand that patient has to be intubated. Please do not wait for anything, because you will lose the patient as well as the baby. Then for oxygen, PaO2, normally in a non-pregnant we aim for 80 to 100, but in term pregnancies we aim for about 95 to 103. pH is about 7.44. And now the last part is bicarbonate. Normally the bicarbonate is around 24, but in these cases it will be 20. Bicarbonate is the buffer which fights against the bicarbonate is the buffer which fights against the acidosis. When the kidney is not functioning properly and it is not able to excrete hydrogen ion, what it does is it creates acidosis in the pregnant lady. And what counteracts it is the bicarbonate. If the bicarbonate is less, then the chances of fighting with that acidosis becomes less. So these patients are more prone to get into acidosis, and then ultimately renal failure, for which dialysis will be required. Okay. This is acute respiratory distress syndrome, ARDS, for which clinical setting is required. It can be trauma, excessive infection, bilateral alveolar infiltrates. That when you will be seeing an X-ray, you will find that both the sides opacity is seen. Thank you. Now there is a technical term, PaO2 by FiO2 less than 300. What is that? PaO2 is the number which you get from ABG. And FiO2 is the oxygen, amount of oxygen you are giving to the patient. Suppose we are breathing air, so 21% of oxygen is there in the air. So 0.21. In an ABG, if the number comes 100 and oxygen, FiO2 is 0.21, the number comes nearly 500. But in ARDS, the number will be less than 300. We need to understand that very clearly. If the number is 300, ARDS. And that reason for that is not heart failure. If we are fulfilling these 4 criteria, then the patient can be classified as having ARDS. Now there is another very simple slide. When the patient is having ARDS, the PaO2 is less, PaO2 by FiO2 ratio is less than 300. We have to go for tracheal intubation and lung protective mechanical ventilation. What is that? We will be giving low tidal volumes rather than the normal high tidal volume which we give to any other patient. Low tidal volume so that we could not have barotrauma, volutrauma or villi, ventilator-induced lung injury. So what are the ventilation targets? So in normal patient, the oxygen target is around only 58 to 60, whereas in a pregnant lady, it should be around 70. The SpO2 target for a normal lady is around, normal person is around 88, but here it's 95. The carbon dioxide target is, for a normal person, it can be even, we can accept, that is called permissive hypercapnia, that can be even 50, 55, 60 is also acceptable. But for pregnant lady, even 45 can be catastrophic. There is something called plateau pressure, that is the resistance which is given by the lung. We have to understand that it has to be kept below 28. Despite our all efforts, we will not be able, sometimes we will not be able to maintain the oxygenation. So what can we do? We can, everyone has seen and heard about proning in corona patients. कोरोना पेशेंट्स when the lung were involved, they were asked कि भाई आप प्रोन पेट केवल लेटिए जिससे कि आपका ऑक्सीजनेशन अच्छा होगा. So that's what is being done. But in a pregnant lady with the fetus, it's very difficult. So at least we can do is semi-proning. वो हम लोग कर सकते हैं. And we have sometimes to go for termination of pregnancy because life of mother is the most important thing here. There's another recent advancement which is ECMO, extracorporeal membrane oxygenator, is like veno-venous we can do where we can improve the oxygenation. I'll not go into much detail about ECMO, but it's a very, very, very interesting topic. Now, if the patient, your patient is having pulmonary edema. Pulmonary edema means patient is having creps. You're just using your steth, you are auscultating the base of the lungs and you are finding crepitations there. You need to understand there are a few things. You calculate the input and the output. If there is a positive intake, most probably the patient is in fluid overload. If the BP is elevated and proteinuria is there, preeclampsia can be the cause. Does the patient has an abnormal ECG, peripartum cardiomyopathy can be the cause. If the patient is on tocolytics, tocolytic induced pulmonary edema can be the cause. But for the basic thing, you need to understand that you need to put the patient in semi-fowler condition administer oxygen either by face mask, or if more is required, you can give a CPAP mask. If more is required, you can intubate the patient. Furosemide, that is diuretics, and strict input-output monitoring. There are certain interesting factors like amniotic fluid embolism.
Can you be a bit faster, please?
Yes, sir. Yes, sir. Amniotic fluid embolism. The women present in labor or undergoing cesarean section, dilation evacuation, or 30 minutes postpartum can have a hypoxia, hypotension, and acute fetal hypoxia. So we need to be very vigilant, and we need to keep our minds open that this can be a diagnosis. For hypoxia, we will oxygenate the patient. For hypotension, we will do the volume expansion, pressure agents, inotropic agents, continue fetal monitoring, and CPR if required. There can be consumptive coagulopathy, PRBC, FFP, cryoprecipitates, platelets can be given. So there was a paper about paradoxical amniotic fluid embolism presenting before a caesarean section in a woman with ASD. This was published by Vijay Kumar sir in the International Journal of Obstetric Anesthesia in 2010. Now, PE in pregnancy. Why pregnant ladies are more prone to having PE? What is PE? Pulmonary embolism. We are talking about pulmonary embolism. Yes, ma'am. Because there is hypercoagulability, there is hemodynamically, there is more plasma volume and blood pressure, there is venous stasis, and immunomodulatory factors are there. So all the factors required for thrombus to be present are there in a pregnant lady. How do we diagnose? We can do it by compressive ultrasound. When we are using the ultrasound probe and we are putting it on a vein, the vein collapses, whereas the artery doesn't. This is a basic thing which we need to know. But if the vein also is not collapsing, normally the moment we keep the probe, the vein collapses. But when we are keeping it and the vein is not collapsing, that means there is a thrombus inside it. And if the lady is presenting with symptoms like dyspnea, hypertension, tachycardia, then you should always suspect thromboembolism. And compressive ultrasound is like, it will take hardly half a minute to do. And if there is thrombus present, then you can just straightforward go and treat the pulmonary embolism. If compressive ultrasound is negative, then we go for chest X-ray. If the chest X-ray is normal, we can go for VQ scan. If the chest X-ray is not normal, we can go for CTPA. We need to understand that CTPA and all will have excessive radiation exposure, but our aim is not fetus. Our aim here is to save the mother. For the treatment, we can use unfractionated heparin in the dose of 10,000 unit BD, maintaining the APTT 1.5 to 2.5. Better would be low molecular weight heparin, which will cause less heparin-induced thrombocytopenia at a dose of 1 milligram per kg subcut BD. We can also go for thrombolysis, but it can have fatality, and warfarin can be used postpartum. Similarly, is venous air embolism. What is the concept behind venous air embolism? That the veins are above the level of the right atrium, so that there is negative pressure, and now there is negative pressure so that the air could enter the vein, and now after entering the vein they will come to the heart and they can block the right ventricular outflow tract. If the right ventricular outflow tract is blocked, then hypoxia, hypertension, same. So first thing what we should do is prevent further air entry, flood the surgical field with normal saline, and second is reduce the volume of trapped air. How will we do it? We'll put a center line, we will be putting it a bit inside the heart so that we could suck the air out. Hemodynamic support, moreover, there is a position in which the patient has to be shifted towards the left lateral so that the air remains above and the left ventricle outflow tract remains patent so that the blood might go. Hemodynamic support is required, and hyperbaric oxygen, even in intubation and ventilatory support can be given. Now, maternal sepsis. There are patients coming to us with maternal sepsis. Generally, here comes the role of the referral, early referral, so that we can actually save those patients.
Excuse me. I think you have to be...
10 minutes more, sir. 15 minutes more, sir. Yeah, I know. After this, we'll be coming. So there is something called obstetrically modified so far. First, we will measure the lactate level, obtain blood cultures prior to giving antibiotics, administer broad spectrum antibiotics, and begin rapid administration of crystalloid, 30 ml per kg of crystalloid for hypotension, and apply vasopressors. We are not supposed to wait for the hypotension to resolve for the fluid resuscitation. You start the fluid resuscitation and immediately start the vasopressors also. For corticosteroids, there is a new recommendation that if you are requiring vasopressors for BP maintenance, then you should go ahead with the corticosteroids rather than waiting. Lactate levels are very important, and we should be
Sorry to disturb you, Dr.
following.
Setu. Actually, our next session will start in a short time.
Yes, ma'am.
So we need to give the other doctors a chance as well.
Yes, ma'am.
I mean, I know you're presenting it really
It's
well,
okay,
and it's very
ma'am.
interesting. It requires a whole conference to
Yeah.
itself.
Yeah.
It's just that we just don't have much time now.
Okay, I'll just ask Dr. Mona Lisa to give her thoughts on the cardiac arrest in pregnancy.
So my topic was to discuss as an obstetrician what is to be done if there is a cardiac arrest in the ward. So of course we all know that there's a code blue which needs to be activated and CPR needs to begin right away. If we are giving CPR or the intensivist or whoever is giving CPR, we need to keep in mind that the rules of CPR, the chest compressions to breath ratio, the drugs, the defibrillation rules do not change because she is pregnant. It is same as any other average adult. Some points need to be noted that if she is pregnant and has a large uterus, uterine shifting towards right side helps in decreasing aortocaval compression rather than giving a propped up position or leftward tilt, which will which might hinder effective CPR. So after CPR is being tried, there's a rule that if after 4 minutes of continuous CPR after a cardiac arrest, a patient is not revived, circulation is not returned, then we need to give consideration to doing a perimortem cesarean section. Now, perimortem cesarean section is done after 20 weeks of gestation. Sometimes in such hurried situations, we do not have the LMB, we do not have the dates. So one simple rule is to see if the uterus size is to the umbilicus or above the umbilicus. If it is reaching umbilicus, she is a candidate for perimortem cesarean section if CPR fails to resuscitate her in 4 minutes. And it is said, it has been reported that if delivery was done within 5 minutes of cardiac arrest, the survival, the revivability of the mother and the baby both are 90%. Now also one point to consider is that earlier perimortem or postmortem cesarean was done with a hope to save the baby when the mother is going to die. That has changed completely now, and now we are doing perimortem cesarean sections to improve CPR outcomes in this patient. The gravid uterus decreases cardiac output, causes aortocaval compression, hinders effective CPR because of the size of uterus. So removing all of this might improve the resuscitation outcomes in this patient. Some points, again, another important point is if we were not able to do it within 4 minutes or 5 minutes, it has been seen that even up to 25 minutes after cardiac arrest, if a perimortem cesarean section was done, baby was removed, 40% injury-free survival in the mother and baby have been reported. I know it cannot be, similar in the practical situations, but still it has to be kept in mind that perimortem cesarean sections can be helpful in patients with cardiac arrest. Now, there are certain rules to remember as an obstetrician that we don't have to shift her to the OT to do cesarean section. It starts just with a scalpel in your hand while the rest of the team arranges everything. Preparing, draping, painting, and Foley's catheterization is not important at all in this situation. Just the baby has to be delivered, and also the CPR has to continue while you're doing cesarean section. It was said earlier that midline vertical incision is suitable, but for me and for most other obstetricians who have been practicing since the last 10-15 years, I think we are comfortable enough with pharyngeal incision. So there's no hard and fast rule. Any kind of incision that can be taken, the baby should be delivered fast, and with the hope that CPR will be able to resuscitate both of them. Thank you, Dr. Sethi.
Very well explained. And now I would like to ask Dr. Vijay to give his views on this topic.
Thank you, Setu. You have seen, I've got some minutes left. You have seen most of the clinical conditions which come to critical care, but the only thing I would add is why we are still delaying our patients coming to critical care units. What I have found is that, not from Patna, but from peripheries, there is facilities are not there. Their antenatal facilities are poor, so nobody told them. Lack of expertise, and obviously lack of healthcare resources. And there is one thing I would like to add, particularly in the hemorrhage cases, that apart from, packed RBC, FFPs, and platelets, I think in Patna, other single donors platelets, single donor plasma, they are all available now. So we should be using those, including cryoprecipitate and, PCC. One thing is, people are using coagulation monitoring devices like TZ and ROTEM, and that usually guides which of the component will be used. One thing I don't know whether people have said that use of epidural pain relief in pre-eclamptic labors patients should be encouraged, because that helps the mother, that helps in controlling the blood pressure, and it's good for the fetal outcome. I think, we are nearly finishing. So, what is the take-home message from all this? That critical care is a teamwork thing, and I know most of obstetricians, you are capable of handling all these, but don't shy away to involve your critical care physicians from beginning if you think is going to need. So
I'm really sorry, but the time has been exhausted. If we could.
Yes, last, and the last I will say that, a specified obstetric ICU should be set up. And that should be with obstetrician presence and internist. So, thank you very much.
Thank you. Can I request all to please come forward for a photograph? And can I request Dr. Alka Pandey madam to join us, Dr. Abarani Sinha madam to join us?